every pregnant woman has a right to deliver safely. She has a right to enjoy life in pregnancy and even after. And the babies too also have a right to live. They have a right to access health care. And many of us in this auditorium are in the healthcare space, and we have a duty and a role to play. So it is important we have a discussion around this very important issue, and that is why we are here today. The sub-themes have been carefully selected to talk to the matter on ground. One of the sub-themes is going to be talking about professionals in diaspora. We're going to be talking about local production of drugs and medicines for pregnant women and for young children and for children. We're going to be talking about the political involvement. What is the role of government? What is the role of the public and private sector in this very all-important matter? And there is a place for investment. Some people have the cloud, they have the fund to invest. In which area can they invest so that maternal health care and safe delivery would be enhanced? And lastly, the fourth sub-theme talks about community-based birth attendants and other healthcare providers. You will agree with me that we cannot do without them. There are unreached communities, far to reach and hard to reach communities where orthodox medicine cannot get to. And the people that are close to these people at the grassroots are these people we call traditional birth attendants. They are community-based. What are their roles? How can we support them to ensure that they offer very good services? So this a foretaste of what we'll be doing here today. Valuable knowledge and information will be shared. Experiences will be shared. And I look forward to a robust discussion. So I want to encourage us all to please sit back, pay attention to the discussants and our guest speakers, and learn. And when it's time to contribute, let's also make our views known. How can we better the lot of maternal health in Nigeria? That is why we are here today. And so, on behalf of SHI and M1 Lagos, I welcome us to this Maternal Summit. I do hope it's going to be worth our while. The deliberation will be fruitful. At the end, we are going to issue a communique and put a call out to government and other critical stakeholders in the healthcare space, especially in the space of maternal health care, to call them to action. So we should all be ready to play our role so that history will have it in our favor, that when the opportunity came our way, we played our role and played it well. Once again, I welcome you all. Thank you.
Thank you so much, Dr. Fumi Ige, M1 President of Lagos branch. And everything she has said is truly what we are doing here today, calling on respective authorities, knowledge sharing, expertise sharing. Thank you so much. And the next thing we have today, we will be having an opening remark from the co-founder of Safe Hands Initiative in the person of Dr. Kemi, which is ably represented by Dr. Bisola. Thank you. Please let's clap for her. She comes.
Good morning, everyone. I'm Dr. Ajayi Abisola, and I am standing in the capacity of co-founders, both Dr. Roland Ojo and Dr. Oluwakemisola Agoyin. So distinguished guests, speakers, and participants, It is with great pleasure that we, the entire SHI team, the Maternal Health Summit Organizing Committee, and also our organizing partners, welcome you all to the 2024 Maternal Health Summit. During this summit, we hope to propel discussions, acquire knowledge, share experiences, and also propel actions from our stakeholders who are here, such as medical health practitioners, our community healthcare workers, governmental agencies, non-governmental and multilateral organizations, the media, and also the general public, towards improving maternal health care services and delivery, both in our nation and in the continent at large. Since 2019, SHI decided to take up the challenge of addressing issues surrounding maternal health in Nigeria. And despite the setback by COVID-19, we continue to forge ahead as we believe that the health of every woman plays a major role in the development of any nation. We're optimistic that the impact of this summit would be long-lasting, with appropriate action taken from the outcome document that will be disseminated from this summit. We hope that beyond today, participants will help spread the messages that are gotten from this summit and also commit towards ensuring quality maternal health care service and outcomes in our environment. We look forward to an educative, informative, amazing yet fun time today as we all come together to make history. Once again, I say welcome. Thank you very much for being here. gone again. Anyway, I'll go on and expect and hope that it comes up before I finish introducing myself.
Once again, we apologize for the delay. And pending that, I would like to remind us of the theme, because if we do not know, the theme of this event is the current state of maternal health in Nigeria. We are looking specifically at the socio-economic determinants and implications. So discussions we'll be having here today, abstract presentations we'll be having here today, even the keynote speech we'll be having today would be centered around this theme. So I'm here to encourage us to pay rapt attention and ask questions and make the best of our time here today. Thank you.
Hey, good morning once again. All protocols duly observed. My name is Dr. Ashade Ituno, like I said before, and I'm a sexual and reproductive health professional. I've been working in the sexual and reproductive health space for over 6 years, and in my 6 years of experience, I've been dedicated to teaching women of reproductive health about access to contraception, the methods of contraception that are available, with the hope and the aim of reducing the incidence of unplanned pregnancies and unsafe abortions. I'm currently a medical house officer at Isolo General Hospital. Coincidentally, I'm doing my O&G posting at the moment. I'm also a sci-fi fellow. Sci-fi is Carrington Youth Fellowship Initiative, which is a year-long initiative that brings together emerging leaders who are passionate about contributing to their society, and gives access to fund and networks that helps us pursue our dreams. So during my sci-fi year, we had a project at Agbowa Ikosi community of Lagos State. I actually discovered the community during my final year medical school posting, community medicine posting. So, we realized that they have issues about maternal health in that community, just like every rural community or almost every rural community in Nigeria does. And so we decided to upskill community-based attendants in Agbowa Ikosi community with excellent maternal health care delivery. And the project was titled Tiwani Health. So the authors are myself, Chiendu Ndu Okoro, Victor Egodage, Muinat Edun, and Osage Enofo. Next slide, please. So as a background, Agbowa Ikosi community is a rural community in Ikorodu, Lagos, with cultural, social, and religious beliefs that directly influence the health-seeking behaviors. So we understand that communities that are rural are very tied to their roots. And so because of the connection they have to their cultural beliefs, their socioeconomic beliefs, this also influences the way they seek health. And maternal health is not an exception. So about 77% of women in that community prefer to deliver under the supervision of CBAs. And what we realized in that community was that it was not an issue of financial constraints. It was not about socioeconomic, facilities. It was just about the fact that it was a preference. It was a thing of, oh, this is what we do in our community. It is the CBAs that take our deliveries. That's what we do here. So we realized that it's important for these CBAs to be, and we realized that these CBAs also, provide family planning services. They provide neonatal and health information and services. And usually they are reluctant to refer their clients when it's necessary.
for reasons that I will mention going into the presentation. So this leaves their women at risk of complications resulting from pregnancy and or childbirth. So our project was introduced to bridge the knowledge gap that was noted among CBAs with the aim of reducing the contribution of rural communities to maternal mortality in Nigeria. So that's a picture of me holding a dummy during the training that we had with them. So our objective is to upskill or was to upskill CBAs to provide improved maternal health services, to strengthen the ties between the CBAs and the health workers. So what we noticed was that before we went into the training itself, we had like a posting or a pre-training assessment where we gave out questionnaires and we also did oral interviews with both the CBAs and the healthcare workers. And we noticed that there was a disjoint in the relationship. The CBAs were standing on their own and saying, they said things like, we are their mothers, even the doctors, we are the ones that gave birth to them. So they cannot eradicate us. And when we began to ask questions like, why are you reluctant to refer? They say, oh, when we send them to them, they take away our clients. They tell them that we will not treat them well. So it was more like, it was more of a competition than a collaboration. And then when you speak to the health workers, you hear things like, oh, they are practicing bad practices, So it's more like everybody is standing on their high horse and nobody was willing. And we realized that, so we tried during this training to strengthen their ties because we understand that at the center of everything is the woman and the baby. So we try to make them understand that if your client is more important than your ego, and is more important than your social cultural beliefs, then that should be at the center of everything that we do. So we wanted to strengthen the ties between the CBAs and the health workers, thereby improving their ability to identify danger signs and refer in order to improve maternal health care outcomes in the community. So our methods, the CBAs were pre-assessed with a semi-structured questionnaire where then we gave that questionnaire as where we got our information, and then we trained them on the best practices in antenatal care, stages of labor, asepsis, neonatal care, and family planning. And this was done in Yoruba language. We had to come down to their level in order to be able to get their attention. And fortunately for some of us, we are very fluent in Yoruba as much as we're fluent in English, So we're able to teach them in Yoruba. We also, showed them samples of family planning methods. We showed them dummies and all of that. We also gave IEC materials to these women, to help facilitate active participation and learning. We also had a community sensitization, which was held to commemorate the this same World Maternal Health Day that we're commemorating today in 2023 with the trained CBAs serving as supervised anchors. Next slide, please. So our results, we found out that majority of the CBAs, they affirmed during the post-training assessment, because we had a pre-training assessment, we had the training, and then we also had a post-training assessment, and they affirmed that they had improved, they had improved confidence in handling childbirth situations. Some of them also agreed that they now have the ability to identify danger signs and refer when necessary. And then we also gifted them birthing kits to improve asepsis during deliveries. I'm struggling to see that part of the presentation. Thank you. So the question we asked, part of the pre-assessment, post-training assessment, was that we asked what their specific knowledge and skills that were gained during the training program was. And we find out that over 50% said that they had better understanding of neonatal care and immediate postpartum care. And followed closely was about 47% who said that they were able to now identify danger signs during pregnancy and also in childbirth. Followed closely was 41.2% who said that they had understood proper asepsis during childbirth. And followed lastly was those who claimed that they had more knowledge about family planning and also information and services. The other question we also asked was what the training had impacted to them. Over 47.1% claimed that it had helped them improve their confidence in handling childbirth situations. 17.8% claimed that it had enhanced their ability to identify and manage complications. 11.8% said that it increased the number of referrals and to healthcare facilities, and another 11.8% said that they did not gain anything. So in conclusion, CBAs remain a highly influential part of the rural communities. They play an important role in reducing maternal mortality. And we understand that they are the major contributors in Nigeria. And our recommendations include that NGOs and the government should take up the responsibility of making these trainings periodical. Because we know that even as medical personnel, we get to go for upgrades and trainings that remind us even of the things that we know. So we hope that these trainings can be periodical. We also recommend that government-owned hospitals in those rural areas, we know that no matter how rural it is, there's always one hospital that is managed by the government. We hope that they can perform oversight functions for these CBAs through their associations, because one other thing that we noted is that these CBAs have a very strong sense of association. So if you want to penetrate them, the best way to do it is through their associations. So if these hospitals can perform such oversight functions, then they will be able to manage the kind of complications and mortalities that come from them. CBAs should also be encouraged to take statistics, because if health workers are taking statistics, then I think they should also be encouraged to do that, which is going to, help to track their complications and mortalities. And this slide is like a picture speaks that gives a breakdown of what we did. So the first slide is when we went into the community and we met with the MD of General Hospital Agboa, as well as the head of obstetric and gynecology department in Agboa General Hospital, because the doctors and nurses, even from the PHC in the community, were the ones that we brought in to train them, while we also supported the training, just to, like we said, strengthen the ties between them. The second slide is when we visited the women. We actually visited them in one cherubim church. I know we had to pull our shoes and enter the church and all of that, and we gave questionnaires to pre-assess them. Then the next picture is that of a doctor from the general hospital who served as one of the trainers. The next picture is my humble self and two nurses. I also served as one of the trainers. I trained in family planning. That's my niche. And then the next picture is a woman holding the training material which we developed and which we also left with them to help them remember the things that we taught them. The next is a cross-section of women, the TBAs, during one of our trainings. The next is a picture of the birthing kits that we gave over 40 birthing kits to each of the CBAs to help asepsis during delivery. The next few ones are, the happy women with their birthing kits. The next one is during the community sensitization that I talked about, where we had both women, men, and children, and we talked about maternal health in-depthly. We also had a session where we taught them soap making of disinfectants to help asepsis during delivery as well. And the last few slides are those of our post-assessment pictures, where we gave IEC materials to the women, and we also met with the MOH of Agora Ikusi LCDA to thank them for their support during the training. So thank you. Next slide. Thank you very much for your audience. That's myself and my team members from Sci-Fi Health Team Lagos. Thank you very much.
So I hope we got valuable points from that, and we would be moving on to the next abstract presentation titled Physical Activity, Maternal Involvement, and Depression. And among postpartum women attending clinics in select us by this American Jews. So we would also have some
Sorry. Good morning, everyone. My name is Atinka Jones. I'm a final year medical student at the University of Lagos, and I'll be presenting my abstract topic titled Physical Activity Partner Involvement and Depression among postpartum women attending clinics in selected tertiary hospitals in Lagos, Nigeria. This was my undergraduate project, and it was conducted under the supervision of Dr. B. Akudu, who is a consultant family medicine physician and lecturer at the College of Medicine, University of Lagos, and Lagos University Teaching Hospital, respectively. Next slide, please. This is my outline. I'll be taking us through a brief background, the aim and objectives of the study, the methods utilized, the results obtained, concluding and giving my recommendations as regards the study. Next slide. As a brief introduction, postpartum depression can be defined as a non-psychotic episode of depression that begins in or extends into the postpartum period. Symptoms of depression include feelings of guilt, sleep problems, loss of appetite, and emotional liability. It is estimated that 1 in 7 women experience a major depressive episode postpartum. Whereas physical activity can be defined as any bodily movement produced by skeletal muscles that results in energy expenditure. It shouldn't be mistaken as exercise. The World Health Organization recommends that postpartum women have at least 150 minutes of moderate intensity physical activity in a week. However, 55% of women do not meet these recommended guidelines. Partner involvement refers to a significant other's interest and participation in the process and experience of pregnancy, childbirth, and new parenthood. These are my aim and objectives of the study. It was to determine whether there were any associations between the variables that I mentioned before, whether there was any association between physical activity and postpartum depression, whether there was any association between levels of partner involvement and depression. It was also to discover whether what the levels of physical activity among postpartum women was and the level of partner involvement. Next slide. These are my methods. This was basically a descriptive cross-sectional study that was carried out at the Lagos University Teaching Hospital and the Federal Medical Center, Importation. It was conducted last year between the months of May and December. I followed due procedure using Cochrane's equation to have my sample size, which was discovered to be 211 participants. I used standardized questionnaires during the course of my study using the International Physical Activity Questionnaire and the Edinburgh Postpartum Depression Scale to collect data from the participants. I also used the statistical package for social services, version 25, to analyze my data. Next slide. Okay, so when it came to my results, these were my results. Overall, 11.8% of the women were found to have postpartum depression. This is equivalent to the Edinburgh Postpartum Depression Scale that I talked about on the previous slide, having a score of greater than 13 and greater. Whereas 79.6% of the participants were said to have good partner involvement. 41.7% were moderately active, while 40.8% were highly active, and this cumulated to 82.5% being physically active. Next slide. Okay, so these were my results when it came to the items that were asked about partner involvement. 17.5% said that their partners accompanied them at least once to antenatal care. However, when it came to things like obstetric ultrasound appointments and attendance at childbirth, the percentages drastically increased. And when it also came to postpartum care, when it came to helping out with the baby, helping up with tasks around the house, the percentages were even higher. But the highest percentage was when it came to providing financial support, which had a percentage of 94.8%. However, the participants were now asked to rate the help that their partners gave to them, because these items on the list were basically yes or no questions, but then they were asked to rate the help that their partner gave them. And only 58.3% said that the help that their partner gave them was very good. Next slide. Okay, when it came to associations, good partner involvement was found to be statistically significantly associated with postpartum depression, especially when it came to the presence of the partner at childbirth, when it came to financial support, and when it came to the overall rating that the participants gave their partners. However, there was no significance between the categories of physical activity and postpartum depression. Okay, now my recommendation. These are mostly based on this study that was conducted. It is important that as healthcare professionals, which a lot of us here are, that we educate postpartum women, we educate the general population about postpartum depression, about the telltale signs and when to seek help and where to seek help. A pivotal point that I noted was, especially during the antenatal and the postnatal clinics, before they go in to see the doctor or the nurse that they came for the visits, that they should be properly educated about these. Also, physicians, nurses, and midwives should be properly trained on screening for postpartum depression in high-risk individuals and its proper management. So it's important that we educate and we also screen. Paternity leave is something that should also be looked into, because if the partners are not even around, they might not be able to participate. So paternity leave should be normalized to promote partner presence and involvement at home. In conclusion, this study highlights the intricate relationship between physical activity, partner involvement, and depression. And it was found that partner involvement and postpartum depression were found to have an association. However, physical activity and postpartum depression had no significant associations. Thank you.
Thank you so much, Atinuke, for your research. And what I took away from that paper was that as healthcare professionals, we are responsible for educating those around us, even in our streets, even in our places of worship, even in professional and unprofessional settings. We should constantly educate people. And also, some of these lessons can be incorporated into antenatal classes for women so that they would be properly enlightened on postpartum depression. Thank you. So before we move on, I would like to acknowledge some of our sponsors for this event. We have Remedial Health, we have Medical Mirror, we have Safer Hands Initiative, which is the chief convener. We have Ethifam, we have Baby Migo. Thank you so much for your contribution to bring this event to actualization. So next up, we have our keynote speech, and I would like to call on a professor of obstetrics and gynecology. Our keynote speaker is a phenomenal voice in the maternal health subsector. With over 100 peer-reviewed publications, it is a no-brainer that she has received an Excellence in Research Award. Our keynote speaker has also been involved in multiple initiatives dedicated to promoting maternal health in Nigeria. Speaking to us on the theme of this event, which is current state of maternal health in Nigeria, with focus on the socio-economic determinants and implications, let us welcome Professor Bosede Afolabi. Thank you.
Good morning, ladies and gentlemen. This looks a bit blurred. Looks a bit blurred, or is it me? Good morning. There aren't a lot of gentlemen here, but good morning, ladies and gentlemen. Thank you so much. I would like to remain on the existing protocol if there was one laid. Thank you very much for having me here today. I'm always passionate to speak about maternal health and issues to do with maternal mortality. I want to congratulate the SHI and Kemi Agoye for inviting me for this. And I really enjoyed your presentations. They were very, I was called outside, but I said, no, I want to listen to this because it's very important about the issue with community birth attendants. So I'm speaking today on the current state of maternal health in Nigeria. I would have liked to be able to see my slides. Or maybe I should stand like this so that I can see them and read them as we go along. I'm speaking today, I have 20 minutes, so I'll be as quick as I can. Looking at the socioeconomic determinants and the implications. Oh, this is bigger. Thank you. So a little bit about me. I work at the College of Medicine, University of Lagos. I'm a professor of obstetrics and gynecology, and I'm also the head of department of the Department of Obstetrics and Gynecology. This is my second term, and I'm already tired. I want to leave. I want to leave that work because I have a lot of other things that I'm doing. I joined the College of Medicine in 1999, so I've been there for 25 years now. Before then, I graduated from Great Ife, Obafemi Awolowo University. 7 years before then, in 1992, I just quickly rushed over to go and specialize in the UK after doing my house job in Louth, because I wanted to quickly do everything. I was in a hurry then. When I look back now, I wonder, what was the hurry about? But I wanted to do everything quickly. So I didn't want to wait to specialize in Nigeria. Then it used to take a long time before you could get a position. So I quickly went to the UK, specialized, and came back because my whole plan was to revolutionize Nigeria's healthcare system, starting with maternal health. That was my plan. Some of my friends that stayed behind will call me, so boss, how has it been? How come the maternal mortality rates are still so and so? I'm like, well, I gave you my best, but I suppose it can't just be me. While I was back in the College of Medicine, I decided that the doctor and the specialist that I had done was not enough. So I went to go do a doctorate in medicine, a DM, like a PhD for doctors at the University of Nottingham. But I didn't leave to do it. I did it at the same time as my full-time work as a consultant and lecturer in Louth and College of Medicine. And it took quite a while, but I got my doctorate in the University of Nottingham in 2011, I believe. And it's helped me become a researcher, a very solid researcher, even if I say so myself. Now, apart from that, though, all these things in medicine, in tertiary level education, in specialization, they are very one-to-one. I came to realize that after a while, that just looking after one woman after the other, even though you feel good, the woman feels good, it's limited. So public health is it, really. So hands up and round of applause for the public health people. It's better to prevent and reach a large number of people than just the one-on-one. One-on-one helps, it's not, I'm not limiting it. I still love practicing as an obstetrician and gynecologist, but it's really better to reach all. So because I realized that, I decided to also form a non-governmental organization called the MRH Research Collective. That was as far back as 2007. And at the moment, we're doing a lot of work in the community, respectful maternity care training, emergency obstetric care training, looking at data in how the PHCs use their data. We're also looking at, there's this project we have called the Mama Base Project, where we're bringing pregnant women in vulnerable communities. We're registering them and we're linking them with community health workers to ensure they register in hospitals, primary health centers, or GHs, and also to ensure that they go for the antenatal care, and most importantly, to actually deliver in healthcare centers. It's been tough. And when I listen to you, I know that we are going through similar things. Some people would just want to stay with their CBAs. You know, some people don't want to go anywhere. And sometimes the access is so poor. There was one community we went to, which I'll show you in a minute, that you can only reach there by boat. And it's not Makoko. I'd never been there before. It's in Ojo. And you take a boat to the place, and then you cross. There was just one bus, one small bus in the whole, you know, community, and there are about 10,000 people living there. I mean, it's amazing. And so you can imagine those people when they want, and the one PHC there had only one nurse, so it was only open for 7 during the day for ANC, but you can't deliver there. So somebody is in labor, and then she goes to call the person, the boss, they call the boss man, or maybe an Okada, to take her to the bank of the lake so that she can cross the canoe. They have to call the canoe to take. I mean, you can imagine how difficult it would be to have that kind of access. So those things, so those are some things we're trying to cover. I also am the director of the Center for Clinical Trials, Research and Implementation Science. We're doing a lot of clinical trials across Nigeria, Lagos, Kano, Kwara, Rivers, Edo States, and Gombe at the moment. And we're doing a lot of interesting work. And I just hope that we're moving the needle one way or the other. And the more we all move the needle, the more we will work towards helping make things up. So I'm talking, it looks like there are a lot of things here. I'll talk about the epidemiology of maternal mortality and maternal more and know the gravity of what we're talking about. Okay, that was me in that Ishagiri community. Talking to some of them. There are quite a number of twins there, incidentally. We saw about 77 pregnant women that day. And then we also saw some women who had just delivered. And there were 3 sets of twins in one place of just one day. So I can imagine that the twin delivery there would be quite significant. This lady here, I think is one of them, she has a baby at the back and one in front. So maternal health, as I'm sure we all know, refers to the health of women during pregnancy, childbirth, and the postnatal period. And the greatest indicator of maternal health happens to be maternal mortality. And it's one of the key sustainable development goal indicators under the broader good health and health being goal. What is maternal mortality? Basically, it is death of a woman who is pregnant or within 42 days of termination of pregnancy, irrespective of the site or duration of the pregnancy, from any cause related to or aggravated by the pregnancy or its management. So, irrespective of the site means that even if it's ectopic, it's not in the uterus. If a woman dies from it, it is maternal mortality. And if it is something that was existing before and not necessarily something like preeclampsia, but something like maybe a cardiac disease and is aggravated by pregnancy, is also maternal mortality. The ones that aren't included are things like she had a road traffic accident. I mean, that one has nothing to do with the pregnancy. She just had a road traffic accident. So for every woman who dies as a direct or indirect result of pregnancy, there are many more women who have significant morbidities. There are a lot of women who end up in ICU, eventually, survive, but they are near miss because they almost died because of also not getting to hospital on time. And that's why public health is so important. If you prevent it, if you teach them how to look after their pregnancies properly ab initio, then they will not get to the level of where they are rushing around and they're dying from maternal problems. So epidemiology wise, every day in 2020, those 2020 figures, when they came out like this, all of us just put our hands on our heads. What is this, for goodness sake? We thought things would improve. They were really devastating. Every day in 2020, almost 800 women died of preventable causes related to pregnancy and childbirth. That's like 1 every 2 minutes every day. So the time we hear about, 10, 15, 20 women, have lost their lives from something that should not happen. In 2020, the global MMR was 223 per 100,000 live births. However, 95% of all maternal deaths happened in lower middle income countries. And of course, as usual, sub-Saharan African countries had the greatest burden of maternal deaths. In 2020, the maternal mortality ratio in SSA was estimated at 5.6 deaths per 100,000 live births. And the countries with the highest MMR were South Sudan, which was in war, Chad, which is also, very beleaguered, and Nigeria. Nigeria was the third. Okay, that's in terms of ratio. In terms of actual numbers, we are number 1 because we have so many people. So Nigeria was had the highest number of women dying, 82,000, just in case you hadn't seen the figures in 2020. And Nigeria's MMR actually increased between 2017 and 2020. In Nigeria, we have quite a few disparities. We have a lot of more death in the north, and this is very high. This is high, and this is moderately high. So even though it's green, it doesn't mean that it is low. And there are communities within the green areas in Nigeria that are actually in Lagos, for example, that actually have like 1,047 as well, 1,050 per 100,000 women. So they are, because of some slums, some of these areas I'm talking about, you have a lot of more deaths than you should. This particular one I wanted to show was about the disparities in using antenatal care and postnatal facilities, as well as delivering in health facilities. If you look at the one to do with delivering in health facilities, you have North Central, Northeast being the lowest, Northwest being the lowest, followed by Northeast, and then you have North Central. And then South is also a bit low, Southwest. But what impresses me the most is the Southeast. Southeast has, they take a lot of iron supplements, they delivered in health facility by 81.8%. I wonder what is different. And I also noticed that even in youth, the Igbo women that book tend to deliver in the hospital, as opposed to the I'm wondering what it is. We should learn from it. What are they doing different? And that's one of the things that you say when in public health, you try and look for there's a name for them. The what's the word now? Determinants, not just the confounders, those ones that are they said they're outliers. Yeah, the outliers, but they're positive deviants. Positive deviants, what I'm trying to say. But the positive deviants are those people. They're doing something different, and it'll be good to learn what's going on there and why it's there. Of course, there are a lot of cultural issues to do with those things. So we know the clinical causes of maternal mortality. Everybody knows that it's been the same for many years now. In LMICs, hemorrhage, hypertensive disorders, that is preeclampsia, eclampsia, sepsis, unsafe abortions, and obstructed labor. We know that. If you give good emergency obstetric care, you are unlikely to meet these things, but that's always been a problem, to have that high quality care. So what actually are the causes in order to be able to reduce these maternal deaths, which are largely avoidable? So when we say, oh, that's what was meant to happen, this woman died, is that not what was meant to happen in the UK or in the US? Okay, US, they say they are bad, but they are just 20 per 100,000, so that's not really bad. Or maybe 50 per 100,000. Why is it that it was meant to be in poor countries and it wasn't meant to be in richer countries, or where they do the right thing? We here have 1,000 per 100,000. In the UK, they have like 10 per 100,000. Is it that it was not meant to be for them? So obviously, there's something that we're doing wrong. It's not fate, it's not determined. It is that there was something, we are not doing the right things. So a lot of them are preventable, but the main drivers, which a lot of us know, include the health system failures, social determinants, harmful gender norms, and external factors. For health system failures, we have the doctors and nurses that are not adequate. We have the health facilities that are also inadequate, and we have things like equipment and things to use. Social determinants, income, education, lack of availability of a lot of resources, tribal issues. That's also the social determinants. Harmful gender norms include, lack of women agency. You don't have, you're not empowered enough. You don't have a choice over what you do with your own bodies and so on and so forth. And external factors include wars and humanitarian issues like climate, and I'm not going to talk about that one. I'll concentrate on the three. So starting with the health system failures. Basically, we have a lot of gaps. Now, regarding the human resources, even before the JAPA syndrome started, we already had poor human resources. We didn't have enough. We see in Lagos you have to take yourself out of Lagos because Lagos is not real when it comes to Nigeria. So in Lagos, we think we're so many, right? But even before the JAPA started, in a lot of places, you don't even have nurses in their primary health centers. You have CHUs. It's that bad. So you can imagine what it's like now. In 2021, over 13,000 healthcare workers from Nigeria got work visas from the UK. Over 13,000 in 1 year. Another figure that I saw was that in that between December 2021 and May 2022, that is 6 months, 727 doctors migrated to the UK alone. 727. 9 out of 10 are going. If there are doctors in this room, 9 out of them or 10 of them are going if they're still within the first 5 years of their graduating. That is what happens. It is really, really an emergency, and it makes things worse. If you say, why are women dying? This is one of the reasons women are dying. I have other figures, but I don't have a lot of time, so I'll continue. Of course, even our healthcare, hospitals, primary healthcare, they're not enough. They're not in the right places when they're, even in Lagos where we feel we have many, some of them are either poorly staffed or they're not in the right places. Women still have to go far in order to get to these places. The services are not always great. We have to admit that. Some of we have to have training and retraining for a lot of things, including emergency care. And then, of course, insufficient financing of the health system and poor health financing protection for women. So when it comes to the social determinants, we have individual family income, access to resources. It shows that when you're poor, you can't get to the hospital better. You stay in places that are far. That's just the way it is, unfortunately. Education as well, whether the woman herself or her husband or her partner, if they're not well educated and if they don't know that this is what you're supposed to do when you're pregnant or when you need emergency, then things like this will happen. And also where they live, cultural belief. Cultural belief is really, really a very big one. And the harmful gender norms, gender inequality. We talk about maternal mortality and all that. And I'm going to be done in the 5 minutes or two, just added now. So we talk about gender inequality, and we don't seem to realize what it affects. When we say a woman cannot make a decision about her own body, okay, so I have some period issues. I can't get up and go and do something until I get permission from somebody else. They don't realize that all these things add up, and that's why women are dying. A woman is in labor or a woman is in extremis. She suddenly has a severe headache. She's almost about to deliver. Her husband is not around and she cannot go to hospital because her husband is not around. That in itself is one of the problems. So those things need to be looked at, and those things are key. When we feel that patriarchy is not a problem, and we don't know that these things link up to people dying, it's a very big problem indeed. Early marriage, female genital mutilation, reduced access to education, inadequate female leadership within the health and finance sector. All these things add up and prevent women from reaching their highest potential. So what are the solutions? Very quickly, from the government, from the health system, and from all of us. For the government, it's clear that resources have to be improved on. We have to, apparently this year, 5% is the highest in a long time, and it's supposed to be at least 15% of the budget, of the national budget dedicated to healthcare. We don't have enough, it should be more. Policies need to be aligned with the goals that are set. There are a lot of things that are on paper, but they are not actually done. And also, different sectors have to be coordinated. It's not just the health sector. Education has to coordinate with the health sector, and so on and so forth. And also environments, because getting access is a very, very big thing, and it's often not happening. The health system itself, there needs to be more equitable access to quality healthcare. There was one woman that we referred to try to get healthcare. She got there and they gave her a booking fee, unbooked fee. This is somebody within Lagos State. She was booked in another hospital because she had unstable life when we saw her in the community. We referred her to a general hospital to try and make sure that she gets good care because she had 4 children. If she delivered at home or something, she would probably lose that baby and possibly her own life. We got her there. First of all, I won't even start saying how much it cost in the end for them to do a normal delivery for this woman, induce and deliver her. But one of the things that I was surprised about was that there was an unbooked fee. I mean, right within the same Lagos State, I think those things are wrong. So we need to have more access to for our women, and also use data more, guarantee access to health insurance, and for our communities, work to identify health and literacy gaps. That's really key. All of the things development partners are doing need to be sustained and evaluated. That's really, really important. And finally, we have to, when I say embracing women, we have to ensure that women actually are seen as a part and a very important part of the community. It's without doubt that if women are seen as less, then they will never get the just deserve in any way, whether it's health, whether it's education, whether it's social, whether it's political. Women have to see themselves as equal, and women have to be seen as equal. We may be different in different ways, but we have the same, capacities and abilities to be. Because the more you feel you have to put somebody down, then that's part of why the person is dying. That's part of why the person is getting violence against them. That's part of why the person is having, a lot of psychological problems, because of that type of stigmatizing. So it is important to embrace women, make sure that they have unhindered access to comprehensive reproductive health care. All those things will now increase their chances of survival, opportunity of having healthy children. And this, even if you don't think about it as altruistic, if it's not about, okay, maybe for yourself, okay, so you're somebody who feels, I don't really want women to be equal. But if you want the country to survive, if you want the society to survive, if you put down half the population, it can't. It's just automatic, sense. So it's important to ensure that women thrive. And that is something that will definitely help improve maternal deaths and maternal, the figures that we have in Nigeria. These are my references. I'm acknowledging Dr. Kemi Agoy and Dr. Onikepe Olabi for helping me with these slides. Otherwise, I wouldn't have had time to do them myself. And I thank you very much for listening to me.
Thank you so much, Professor Abosede, for the enlightening, Professor Bosede, for the enlightening lecture. And before we go on to the next scene, I would like to ask if there are any questions for our keynote speaker. Do we have any questions? No questions. No questions. Okay. So I would also like to. Okay, just one question. I'm taking just one question. All right, thank you.
Thank you very much for the wonderful presentation. I just have one question for you, and probably the entire health practitioners that are here. I've seen different presentations, but there is something that bothers me, and that is in educating women concerning pregnancy, childbirth, delivery. There is a lacuna in the area of the different modes of delivery. That is vaginal and CS. Because in this particular place, this particular state, I'm a mother of 3. In my first children, I used normal delivery. But in this last one that I delivered last year, it was CS. And it was not like I planned it. It was not like normal. I carried my bag, like jumping to the hospital like normal, right? But I got there, now, medical people, they start speaking big English, moving up and down. I was not understanding what was happening. I was asking questions. Doctor would say, relax, Madam Ibe, we'll come to you, So I wasn't prepared, even though I was judicious with my antenatal care, right? So I think there is need for more education and I have realized that even our nurses are not doing, when it comes to discussing cesarean section. And once you call cesarean section, a lot of mother women, pregnant women, God forbid, it's not my question, and all of that. So I think there is need for serious education on cesarean, because even the day after I had the CS, when they moved us upstairs, there was a case of a woman that refused cesarean section, even when that was the only means for them to save her life and her baby. We even have to start, even when we are still trying to, for the whole thing, the injection to go, we are begging her. Because when they brought, she came upstairs and the nurses were begging her. So I think there is need for more education. I don't know, you have a lot of, things on your sleeves. I think you should champion this. Cesarean section is something that women should start talking about. It's not I have done it now. I can see it's not a death sentence. It's even easier safe. So seriously. So yeah, I think that's what I want to say. If there is anything on it, and how well are they championing that discussion? Thank you very much.
Thank you very much for that lovely contribution and question. Really, really a good one. The thing about it is that because there's such a big problem, and we don't even look at that. We look more at how we're going to reduce the numbers of women dying, not remembering that part of what is important also is that part of that respectful maternity care is actually to communicate with our women better. So we do need to communicate with our women better. Incidentally, my only child was born by cesarean section, and that was because she was breech. And when I said to my mother that, oh, I'm going to have a cesarean section, she was like, God forbid. I'll never forget that day. I was just laughing. Like, you feel that you're the most educated woman in Egbaland. You're the one that is also saying, God forbid. So obviously, there is that stigma. There is that feeling of, oh, it's a bad thing. And we should incorporate it more into our health talks and let women know that it's not a big deal, and let them know why it may happen. Some people that even go into labor thinking that they're going to have a normal delivery sometimes end up with a cesarean section. Yeah, and that's part of why some women don't even come to hospital, not realizing that it's not a big deal. So yes, you're very right, and we've taken note. And that's one of the reasons why it's important to have things like this. Thank you.
Thank you so much. Thank you. Thank you. I would like to acknowledge again our sponsors. I'd like to acknowledge Kensington and Impact Her World Foundation, Medical Mirror, Lagos State University Sickle Cell Society, Farm, and Remedial Health. Thank you so much again for your contribution towards this event. Also, I would like to acknowledge the presence of our virtual participants, because truly this event involves you all that are joining us virtually. We have Dr. Joy O. Hazy, which is the founding member of Birthing Kids Foundation Australia. She's virtually present and she has joined since. And also Associate Professor Aduragbemi Banke-Thomas from the London School of Hygiene and Tropical Medicine, UK. We also have our mutual partners, members, and founder of Value Female Network. I'd also like to acknowledge the members of M1, Medical Women's Association of Nigeria. Thank you so much for your presence. Thank you so much for your contribution. This event would not be possible without each and every one of us. So calling on the next presentation, abstract presentation, or the topic for the presentation is knowledge, attitude, and preventive practices on human papillomavirus vaccination amongst mothers of adolescent girls in selected secondary schools of Ikeja local government area. So can the presenter please? Thank you so much. Thank you. So please let's welcome him with a round of applause.
Hello, good morning, everyone. My name is Sakim Yakimbali, and I'm going to be presenting the abstract for this research work carried out by my colleagues and I from med school, titled Knowledge, Attitude, and Preventive Practices on HPV Vaccination Among Mothers of Adolescent Girls in Selected Secondary Schools of Ikeja local government area. I think I'm the first man to take the stage today, and I'm truly honored. Okay, this is the outline I'm going to be following. I'm going to talk about the introduction, background of the study, the objectives, methods, results, and recommendations. So briefly, human papillomavirus is a sexually transmitted viral infection that majorly causes genital warts and cervical cancer, but it can cause other diseases as well. Now, HPV is particularly important because every individual who is sexually active will contract HPV at some point in their lifetime, almost everyone. And some people may be infected more than once. And this infection can persist in about 10% of infected people, increasing the risk of developing cancer. So HPV, again, as I've said, is implicated in nearly all cases of cervical cancer, as high as 95% according to the WHO. And globally, most HPV infections are seen among young women and women of reproductive age. And cervical cancer is also the second leading cause of cancer-related deaths among women in Nigeria, second to breast cancer. And when it comes to cervical cancer, low and middle-income countries like Nigeria have a higher incidence rate and a lower survival rate. And developing countries as a whole bear over 85% of the global burden of cervical cancer compared to developing countries. Now, being able to prevent cervical cancer, most commonly the Cervarix and Gardasil vaccines. So using these as primary preventive measures, in addition to screening for HPV as a secondary measure, makes cervical cancer a disease that is almost entirely preventable. But yet, among developing countries like Nigeria, we have a lower vaccination rate and lower screening efforts, which makes vaccination a very crucial strategy to reduce the incidence of cervical cancer among these countries. So the WHO recommends that young girls receive the HPV vaccines between the ages of 9 and 14. And these are the ages where children are still under the care of their mothers. So understanding the vital role that mothers play before their children can be protected against HPV and consequently cervical cancer, we aim to evaluate the level of knowledge, attitude, and preventive practices on among these mothers, as well as the factors influencing these attributes. So we carried out a descriptive cross-sectional study with a sample size of 312, and we collected data through self-administered questionnaires exploring the various attributes we wanted to test, and analyze this data, generating frequency tables and using a chi-square test to determine the association between categorical variables. So briefly, most of our respondents had a mean age of 42 and most of them were married. Now, when it came to their knowledge on HPV, only about half had not heard of HPV or didn't know what HPV was at all. And we used the point system to grant the overall knowledge of these respondents, the mothers, on human papillomavirus using the knowledge segments from our study tool. And we found that most of them have been poor overall knowledge. Over 60% of mothers had poor knowledge on HPV. For example, only about 60% correctly identified that HPV was sexually transmitted. Others thought it was spread through food, through the air, etc. A majority of mothers also had a positive attitude towards vaccinating their daughters. Over 70% were willing to vaccinate their daughters. And it's expected the proportion of mothers willing to pay for vaccination was lower compared to if vaccination were free. Now, when it came to the preventive practices, only about 14% of mothers had daughters who were vaccinated. The majority of mothers had daughters that had not received the vaccine at all. And among those who had been vaccinated, most of them, over 80%, arranged for these two school-based vaccination programs. While among those who were unvaccinated, the major reason given for not being vaccinated was that mothers did not know where to get the vaccine. Now, when it came to our associations, the most significant determinant we found was that there was a relationship between the educational status of mothers with different parameters, including their overall knowledge on HPV, their attitude, their awareness, as well as the proportion of who had been vaccinated. Another significant association we found, which I did not include in the slide, but I was tempted to mention is after listening to Professor Afolabi's keynote speech, was that a greater proportion of Igbo residents, Igbo respondents rather, had a more positive attitude towards vaccinating their daughters. So I guess more research needs to be carried out to understand why they have a more positive attitude towards maternal health generally. These are just a few charts showing our results. The pie charts at the left shows that the major source of information on HPV among our respondents were health professionals, followed by mass media when taken to include radio, TV, newspapers, and magazines. And the compound bar chart on the right is showing the respondents or our knowledge on HPV categorized according to their educational status. So the green bar represents good knowledge. And we can see that the green bar is tallest among those with tertiary education, while the red bar represents poor knowledge, and we consider that's the tallest bar across all educational statuses. So based on our findings, we made the following recommendations. First, that we need comprehensive school-based awareness programs because we believe this is the best way to reach the key demographic that will benefit from these vaccines by incorporating HPV information into school curriculum and parent-teacher meetings. Also, recommended that health facilities be leveraged so when mothers and their daughters prevent for different health reasons, this opportunity is taken to educate them about HPV, cervical cancer, and the importance of getting their daughters vaccinated. And also, obviously, the role of mass media cannot be overestimated because it is the best way to reach wide audience. And also, we need the support of governments and other organizations to improve the accessibility of vaccines to all mothers. In conclusion, our study highlights the poor overall knowledge on HPV among mothers and highlights the importance of improving preventive efforts and access to vaccination services among women so that we can strive towards a future where every girl child receives a future where she's protected against this preventable infection. Thank you.
Thank you so much for the brilliant presentation. It was short, yet value-packed. I'll be calling on the next presenter, which will be presenting an abstract on the topic, leveraging the role of community-based birth attendants for continued maternal care provision and reduction of maternal mortality in Southwest Nigeria. Can we have the presentation uploaded, please? So pending that, I'd like to inform us that our tea break is, we'll be having the tea break soon. So let's be calm, let's buckle up and enjoy the event. Thank you so much. Hi, so it seems the presenter for this abstract is unavailable. Does the person need more time? Okay. So we'll be moving on to the next thing for our agenda today, which is the panel session. Thank you so much for the presentation so far. Now is the time for our first panel engagement, and it is the time for brilliant stakeholders to rub minds together. So I'll be calling on the citation of the panelists. Dr. Joy Ohezi, she's joining us virtually. She is a medical practitioner with rich experience in administration and strategic planning. As the outstanding leader that she is, she played an instrumental role in the development of the concept of birthing kits. This followed her attendance of the UN Fifth World Conference on Women in 1995. She has been practicing medicine and making generational impacts even before I was conceived. Then Dr. Joy Ohezi is currently the deputy chair on the board members of Birthing Kits Foundation Australia. She started the production of the birthing kits to be distributed to women and birthing attendants in low resource and emergency settings. Supported by members of the Zonta Club of Adelaide Hills, she was an original member of the Zonta Birthing Kit Committee and an inaugural board member of the BKFA. She brings specialist skills in maternal health research and informs the board on matters of medical information research. Let us kindly welcome Dr. Joy Ohezi. She's a panelist joining us now.
Thank you very much.
Yes, and I will be calling on another panelist, Professor Rosemary Ogu, which is ably represented here. Currently, Professor Rosemary Ogu is currently the National President of the Medical Women's Association of Nigeria. Professor Ogu is a consultant obstetrician and gynecologist and past head of the Obstetrics and Gynecology Department at the University of Port Harcourt and University of Port Harcourt Teaching Hospital. Graduating MBBS with distinction, she completed her residency in 2008 and earned her the fellowship from the West African College of Surgeons and the National Postgraduate Medical College of Nigeria. She has an MSc in Reproductive Health degree from the World Bank Center of Excellence in Reproductive Health Innovation, CERHI, domiciled in the University of Benin. Professor Ogu is also a faculty member of the National Postgraduate Medical College of Nigeria. So we'll be waiting for her representative in the person of the M1 Lagos branch, Dr. Umi. Thank you so much, ma'am. I've got the presentation already. And our next panelist, Dr. Aduragbemi Banke-Thomas, he's joining us virtually too. Dr. Aduragbemi is a physician, public health practitioner, policy expert, and global maternal and newborn health researcher. Presently, he is the Associate Professor of Maternal and Newborn Health at the London School of Hygiene and Tropical Medicine, United Kingdom, where he is also co-director of the Maternal, Adolescent, Reproductive, and Child Health Center. In addition, Aduragbemi is Health Systems Research Lead at the Maternal Reproductive Health Research Collective in Lagos, Nigeria, visiting research fellows at the LHC Health, London School of Economics and Political Science, United Kingdom, and principal researcher at the Senghor Chair in Health and Development in Sub-Saharan Africa, University of Ottawa, Canada. Thank you so much, Dr. Aduragbemi Thomas, for joining us. We also have Dr. Modupe Adedeji. She's the consultant gynecologist with a wealth of experience in medical practice industry. Joining us today as a representative of Society of Gynecology and Obstetrics, she is the Assistant Secretary of the Lagos sector. We also have Dr. Benjamin Dozie Anyanwu. He is a US-trained neurologist. He's a US-trained neurologist with additional subspecialty fellowship training in vascular neurology, neurology and neurosurgical center care. Under his impeccable leadership at Novant, the hospital received several gold performance awards in stroke care from the American Heart Association. With his wealth of experience, he volunteered his knowledge and expertise to help found the first stroke hospital in Nigeria. And our last panelist for this session, we have the panel session moderator in the person of Dr. Okweyemi Oladunjoye. She is currently the Chief Operating Officer of Fini Medical Center. Dr. Oladunjoye has over 6 years of clinical, management, and consulting experience in public and private healthcare organizations, obtaining her MBCHB degree from OAU and a Master's in Public Health degree from the United Kingdom. She has a track record of accomplishments in healthcare administrations, operations management, organizational planning, and business development and strategy in the healthcare industry. Both a member of the Medical and Dental Council of Nigeria and the General Medical Council UK, she's also an associate of the Women in Business Management and Public Service Association and a fellow of the Women in Boards Mentorship Program. She will be moderating the panel session. Which is focused on the sub-theme titled The Role of Healthcare Professionals in Diaspora in Improving Maternal Health in Nigeria. Thank you so much.
Can everyone hear me now? All right, great. Hello, everybody. Good morning. I hope everybody's having a good day so far. All right, so we're here for the first edition of the SHI Summit. And just like Prof told us earlier, this is a very, very important topic. And it's a great thing that we have platforms like this to be able to remind ourselves of the importance of maternal health and the actual data that we have in areas of the world like this. Sometimes because we have people around us who get pregnant and deliver very easily, it's very easy to forget that it actually kills women every hour in Nigeria. So it's just a great reminder for us to know that we still need to continue committing our resources every day to this scourge in Nigeria. So I would like to welcome everybody again. And I will be introducing Dr. Ege first, as she's representing Dr. Rosemary Ogu. So, Professor Rosemary Ogu, rather. So Dr. Fumi Ige is the president of the Medical and Women's Association of Nigeria, Lagos State Branch. She's an astute physician and anesthetist, the head of anesthesia department in General Hospital Aurelia Agege, and she's dedicated to the advancement of maternal, child, and adolescent health in the state and beyond. So thank you again to all our panelists, both present and virtual. Please let's have a round of applause again for them.
Thank you.
All right, so we'll go straight into it. And we are talking about the roles of diaspora, doctors in the diaspora physically, or let's even say at large, health professionals in the diaspora in improving maternal health in Nigeria. So I'd like to throw it to you, Professor Aduragbemi, first of all, sir. We had a presentation earlier from our keynote speaker, Professor Abiodun, and she mentioned that
virtually every 2 minutes in Nigeria, we lose a woman to maternal mortality. She also mentioned that about 13,000 health professionals have left Nigeria within the past 1 to 2 years. We all know about the Japa syndrome. Many people, when you talk to them, when people who have left Nigeria, they tell you, oh, I'm going to come back maybe when I want to retire or after retirement to establish something. Looking at the current state of maternal health in Nigeria, what do you think are the gaps in maternal health care that our professionals who have left can come back to fill? And how do you think they can contribute to improving our numbers? We would love to have practical examples so that people who have joined us online and even people here that are planning to migrate can have that at the back of their minds and come back and save us.
No, excellent question. Thank you so much for that. And once again, just a big thank you also to you, the organizers, Mary, for inviting me to this to this summit. So I think first of all, the problem is well recognized. We know that there is a problem. That's not what we're discussing here. In fact, I think it's probably better to say that it's quite embarrassing for many of us that the numbers of maternal deaths in Nigeria, the giant of Africa, remains quite sobering. It shouldn't be that. However, the solution is multifaceted, and I think sort of bringing in health professionals in diaspora to contribute is certainly an action that we need to definitely take. I know for sure that there are huge roles for health professionals in diaspora to contribute positively to maternal health in Nigeria. But I do not believe that has to be provisioned on the need to sort of create a conducive environment for them. You talked about the Japa syndrome. There was a time when everybody who was abroad and I was born abroad. I think this is for the Yorubas. They were called Tokumbo. I think Professor Falabi was speaking earlier. She would probably be one of the Tokumbos. It was pride to come back home. But I think we are very much in the Oluwabami Japa this generation now, where as soon as you go, please don't let me even come back. And I think there's certainly a moral duty for us to sort of contribute to that and make a difference. To your specific question on the sort of practical examples of how it can be done, looking at the current state of the nation, I see 3 key gaps that I think healthcare professionals in diaspora can feel and contribute to. I think the first one is certainly research and research capacity. We know the problem, but we do not know enough of what needs to be done. We do not know what is effective. We do not know how what is effective can be better implemented in our own setting. In many of the colleagues, many colleagues who work in diaspora, research underpins a lot of their clinical practice and policy. You do not do anything without sort of reviewing the evidence base to inform how you move forward. We still have a lot of politics. Of course, there's politics everywhere, but we still certainly have a lot of politics that inform how we do things. So I think sort of infusing and leveraging the research capacity of many healthcare professionals in diaspora, would have been forced to sort of upscale their own research capacity is something we can leverage back home. 2 is funding. Let's create platforms that allow healthcare professionals in diaspora to send Forex back home in Nigeria. We know it to go further than what can be done abroad. And in doing this, obviously, we need to make sure that some form of routine reporting that allows folks who contribute to this, to understand and know the difference that their financial contributions are making to do good. I think that would be great. And I think the third one is really expertise. I know there are a number of ventures that do this in many other specialist disciplines. You see cardiothoracic surgeons coming back home to help with open heart surgery. You see, you see emergency medicine happening. I think we need this in maternal health also. We need obstetricians who will come back and sort of boost the capacity in our tertiary facilities. So I think if such platforms and opportunities can be created, those will certainly make a difference. Thank you.
All right, thank you very much for that answer, sir. So I would like to ask you, Dr. DDG, how do you think we can create a conducive environment for people who actually want to return, to come back and set up and help us reduce this number?
Thank you very much. I'm happy to have been invited. As earlier said, I'm representing slogan is, please don't mind my voice. I've lost it from time. And I keep skipping NT clinic. I don't know why. So please don't mind my voice. So I'm representing Society of Obstetrician and Gynecology Nigeria. It's actually an association that champions maternal health in Nigeria. And I'm the assistant secretary, as earlier said. So yes, it's so important. And that maternal health is very dear to, how will I put, which part of our body should I use? Is it the heart or the soul? Or it's actually daring and sad how our mothers die. For instance, I work here in Lasut, and we tend to have a meeting every morning to review our cases and all that. You know that this morning, we still had 3 deaths, 3 maternal deaths this morning. And then one of the cause of death was acute pulmonary embolism. And how acute, for those of us that are health practitioners in the house, I'm sure you understand the feeling, because I had some, if you don't get it right, in few minutes, maybe around an hour, patient goes away. And what is so pathetic about that death was that it was even an pregnancy, So, that's quite painful, and more painful when you even hear, is what the kid notes, that people that are even in the suburbs. When she showed the picture that she was standing, a whole professor in Nigeria, Lagos, international, and standing in front of those women that are in the suburbs, and you have them, 77 of them, pregnant in a small community, and you are having twins. You can imagine what is happening there. So we still have a lot of things to do in the country. And what speaks about the country is actually the health and the education, because it's the healthy people that will go to school. And we also need the school to kill our ignorance and know what to do, to empower our women and all that. So where do the diasporans, where they come in? Most people have gone majorly just because of self-love. Can I put it like that? And everybody is even looking for a possible way to get out. There was a day I escorted a friend of mine to Japa, and that was even the period when dollars was really high. And I still saw the crowd at the airport. They were living as if the money is just about 5 naira to leave the country and all that. So it's so important that we remember to come home. But we have to make the environment conducive for them. While preparing for this panel, I had to go on the net, and I saw that, yes, a whole book has written by the ministry concerning policies, that's how we can encourage our diasporans to come back. But yet, the books are there, but the actions are nowhere. I don't know how much we are praying for prepaid meter. And that is so germane. Light is so important for people that are into the health sector business. One thing that you have to service is light, 24 hours light. Imagine taking deliveries with phone lights. We talked about cesarean section now, and you are doing a section and the light goes off. Imagine that and all that. Even the baby that is coming out, that may be preterm, that you just need incubators. That's another thing where they can play their role. Equipment. You need incubators, but the lights must stay. And then the buildings, we can't work virtually. We can't do this virtually. We still have to do it physically. So the buildings, how accessible is it? How are government supporting? It's actually a lot of things to say about them coming. And then even those of us locally, we also still are crying out that we want to do our best. The keynote speaker also mentioned the fact that people are going away, and the fact that even the people around are overworked. So the problem is big in order to actually to reduce these indices.
Let's stop. We are running out of time, so thank you so much for that. So I love what you mentioned. You focus on a lot of urban problems that we have, like electricity and equipment. Now, one of the things I found interesting while seeing the bios of our panelists was that Dr. Oezi is involved in the production of birthing kits that are then given to birth attendants and health workers and mothers in Australia. This seems like a local problem, in quotes, or local answer rather, in quotes, adopted in a very advanced place like Australia. So I would like to ask you, Dr. Oezi, what are the policies and developments that you think that we can adopt that are practiced abroad and in better climes, in quotes, that we can adopt in places like Nigeria and sub-Saharan Africa at large to improve our numbers?
You may be interested to know that in Australia, we have problems getting doctors to work in our rural and remote areas as well. I actually have spent 20 years working in the remote areas. I go a few days a month to provide women's health because we cannot keep local doctors now. We have doctors that are trained overseas to come and work in our rural and remote areas. So it's not just a Nigeria problem, it's actually even other developed countries have that issue. But I mean, I'm not a diaspora. I wasn't brought up in Nigeria, but as a health professional with the education that I was very lucky to receive in Australia, I perceive that as the information that Professor Olang Afolabi provided, that's all available. So I'm aware that Nigeria has the biggest issue in terms of the number of women that die in childbirth. So our organisation, Birthing Kit Foundation, provides support to those that are working in the country, not necessarily health professionals. They're actually NGOs, organisations that do community development. So we're not relying specifically on doctors and nurses. We actually are looking at supporting those that do actually remain in the community, in the local areas, and helping them improve what knowledge they have and the capacities they have. Now, we only provide birthing kits, but we also do provide some education, which, as everyone has said, is a very important component. We can only do so much. We only have a certain amount of resources as well, but that's where we have put our information, and we work and collaborate with people on the ground. We have about 5-6 partners that we work with in Nigeria, and we have done for some of them for 10 years, the Rotary project that's organised for maternal and child health. So we don't provide the services, but we support those that are actually there doing it. So I suppose if you had some of the diaspora, even if they're not able to be present, they can probably provide some support and resources for the local individuals that are there and doing what they need to do for the local women.
Thank you so much, Doctor. So, Dr. Ige, I would now like to ask you, you are the president of Medical Women's Association in Nigeria. I'm sure that in recent times, a lot of your members have left Nigeria, including Kemisola, I have to say that. But now we've talked about the need for human resources. We've talked about the need for equipment. We've talked about the need for support generally. How are associations like yours maintaining communications, or how can we generally ensure that that link is maintained to people that have left so that when they come back, they don't find it too difficult to put these things into practice?
Thank you very much for having me and for your question. Let me quickly correct your introduction. I do not work at Orile General Hospital. I work at General Hospital Ifakoijayi. Right. That said, yes, indeed, a lot of our members have jackpot, but we don't just let them go like that. We have a WhatsApp platform where we have members who are based in Lagos and those who have traveled out or who live there. Kemisola Agoye is one, and it is from diaspora that she has managed to convene this gathering. Please just applaud her for that. So communication is key, is very important. So it's like when you have loved ones, family members pull out. say because they have traveled, you won't have any link with them anymore. We keep coming. So ensures we do that. And we've had members who from where they are have contributed their the progress of their Aguri, who is doing something like this. Another member who at a biennial meeting donates items. 2 years ago, she donated a box, a laptop for the use of the secretariat and things like that. So communication and partnership is very important. Just to also add that the environment also has to be made enabling by way of security. If I'm going to come home after I have traveled out to come and contribute to my quota to improve our health indices in my own little way, then the least the environment or the nation owes me is my safety. So security is very important. Transportation, traffic management is very important. I'm going to come and lend my hand in doing one or two things and render service. I should be able to commute relatively easily. So these are some of the challenges that we have that I think we should work on. But everyone on our role keeps collaborating and partnering with members both at home and abroad to ensure that we contribute our quota to improving our maternal health indices. Thank you.
All right, thank you so much. So finally, I would like to say that I think there's also a room for the private industry to come into this. We've talked a lot about diaspora. Well, as someone from the private community, basically, I think it would be great for us to continue fostering relationships between public and private sector to ensure that we save more lives together. So with that, we've come to an end of our session, and we hope that you all got a lot of information from this, and together we can work together to make the numbers better. Thank you so much. Thank you so much, Dr. Okwemi, and remarkable panelists for that wonderful knowledge sharing. Now we'll be stepping out for our tea break. But before that, I'd like to acknowledge again our partners, because without them, we would not be here. We have Value Female Network Africa, we have Mother and Child Health Projects, we have the Medical Women's Association of Nigeria, we have Healthcare Analytics Consults. So, and this tea break, we would take about 10 minutes. It's not going to be long. Just have a little snacks to munch on so that we would be re-energized for the next part of this event. Thank you. So the place for the tea break is right there. Okay, there's an order in which we would step out for the tea break, because eating is not allowed inside the hall. That is why we have to step out to have tea break. Please, orderly, from the front row. So we have. Thank you. And follow her.
while the tea break is going on, there are props. You can take pictures, post on social media, use the hashtag International Day of Maternal Health and Rights, Safer Health Initiatives, and tag our sponsors, tag our partners, so that everybody will know that, yes, something happened here today. Thank you.
On this journey.
Imagine a plane full of pregnant women and the promise they carry crashing every day. Well, that is the equivalent of what happens in Nigeria. In 2020, around 82,000 women died preventable deaths while giving birth. That's 220 mothers, daughters, sisters, and wives lost every day for 365 days. That is more than a statistic. It's a crisis. No woman should die while giving birth.
Orúkọ mi ni Ìyáàfin Onífádé Fáfọláhàn tí mo jẹ́ agbẹ̀bí nílùú Òṣogbo.
Ní èyí tí èmi gangan tí mo bá yín sọ̀rọ̀ ti wà lẹ́nu ẹ̀. Ọdún yìí ló pé 30 ọdún tí mo ti wà lẹ́nu ẹ̀.
Mo lọ sí teacher training. Mo jáde ní NC Iléṣà. Ṣùgbọ́n iṣẹ́ agbẹ̀bí wù mí púpọ̀ torí iṣẹ́ àwọn òbí mi ni. Mi ò dẹ̀ ní àǹfààní àti lọ school nígbà yẹn. Mi ò lẹ́ni tó lè ràn mí. So mo wá decide pé kí n lọ sí training, kí n ṣe training lọ́dọ̀ àwọn tó jẹ́ doctor private hospital. Mo dẹ̀ lọ fún training yẹn fún 3 years nígbà yẹn. Ìgbà tí mo wá parí, mo bẹ̀rẹ̀ sí ní ṣiṣẹ́ káàkiri kí n lọ auxiliary nurse kí n lọ sí hospital kéékèèké mo ń ṣiṣẹ́ tí mo dẹ̀ ń gbowó tí mo fi ń manage. Ọkọ tí mo wá fẹ́ bàbá ẹ̀ wá jẹ́ pé irú iṣẹ́ ìgangan náà ń ṣe. Bàbá yẹn ló wá dá mi dúró pé instead tí mo fi ń lọ káàkiri yẹn kí n fẹ́ kan dúró táwọn ìbílẹ̀ ni wọ́n pé kí n mọ báwọn manage mo ṣe wá di ògbóǹtarìgì nínú agbẹ̀bí ìbílẹ̀.
Mo ní staff méjì lọ́dọ̀ mi báyìí tó yẹ pé wọ́n wà ní clinic báyìí bí mi ò ṣe sí ní àwọn akọ́ṣẹ́mọṣẹ́ ni mo gbà nọ́ọ̀sì wà lọ́dọ̀ mi.
Mo ń ta àwọn ọjà wẹ́rẹ́wẹ́rẹ́ mo ń ta àwọn baby care mo dẹ̀ ń ta àwọn aṣọ mo ní shop tí mo tún fi ń manage mo ra àwọn bẹ́yìn bẹ́ẹ̀ tí iṣẹ́ agbẹ̀bí yìí òun gan ni kókó tí mò ń ṣe tí mo gba àwọn èèyàn síbi tá a ti ń ta ọjà wẹ́rẹ́wẹ́rẹ́ yẹn ni bẹ́ẹ̀ tí iṣẹ́ agbẹ̀bí kò sígbà tán lè dé wọ́n máa bá mi ń bẹ̀.
ṣùgbọ́n nípa ìlóyún àwọn èèyàn máa wá tààrà ṣùgbọ́n nípa ìbímọ ní máa ń jẹ́ tí máa dínkù díẹ̀díẹ̀ nítorí pé ọ̀pọ̀lọpọ̀ tí ń bá ń gba àgbo lọ́dọ̀ wa tá à ń tọ́jú ẹ̀ ẹlòmíì ó lè ṣeé ṣe kó jẹ́ pé ọjà ní bíbímọ rẹ̀ ọba kí wọ́n rọ̀ sí ẹ lọ sí hospital tàbí lórí ìrìn tàbí hospital ti eléléèbó ní ọ̀fẹ́ wù kóhùn bímọ sí àyàfi ẹni tí ọba jẹ́ pé ọ̀dọ̀ wa ni ó nífẹ̀ẹ́ sí jù ni yóò wá sí ọ̀dọ̀ wa.
Ìgbàkígbà tí wọ́n bá ṣetán láti bímọ tán bá ti dé ilẹ̀kùn ti ṣí náà nìyẹn. A ní rẹ́gísítà a ní káàdì tá a máa ń fi fún àwọn tó bá wá rẹ́gísítà kan wá lò wá bímọ. Owó táṣẹ́rẹ́ náà ni la máa ń gbà lọ́wọ́ wọn láti fi rẹ́gísítà 500 naira káàdì. Lẹ́yìn yẹn a máa sọ fún wọn pé tán fi máa deliver owó tá a fi máa ṣe treatment fún wọn wọ́n á máa san díẹ̀díẹ̀ ó pọ̀ náà kò pọ̀ púpọ̀ bóyá bíi 10 bóyá 15 gbà mí tá a máa ń gbà lọ́wọ́ wọn lówó kéékèèké wọ́n dẹ̀ máa ń wá dáadáa. Ní ọ̀dọ̀ wa mo gba dókítà tó ń bá mi treat àwọn èèyàn à ń gba abẹ́rẹ́ àjẹsára à ń ṣàtìnáńtà tá a bá dẹ̀ ní patient tó bá ti fẹ́ di pé kínní màá refer rẹ̀ mo lọ hospital tí mo máa ń refer wọn sí tá a máa ń lò.
Refer yẹn tiẹ̀ ó yá sá wa lọ́wọ́ tiwa ní Òṣogbo yìí tí èèyàn kan bá ní patient tí ò bá refer ẹ̀ ẹgbẹ́ máa gbé sísẹ̀ so a máa ń refer patient tá a bá ti mọ̀ pé a lè handle ẹ̀ a máa refer sí hospital.
Nígbà míì iṣẹ́ tọrọ yóò wá tó jẹ́ pé bá ti ń fi orúkún kan kúlẹ̀ náà ni wọ́n máa fi kejì dìde òmí gbà míì a sì máa ní delay status tó já sí wípé a ti fọkàn sí wípé bóyá láàrin wákàtí kan tàbí ìṣẹ́jú márùn-ún ìní ó delivery ṣùgbọ́n bó ti wọlé ní ṣe sọlẹ́ rẹ̀ ó lè tó wákàtí méjì tàbí mẹ́ta tàbí ọjọ́ méjì gan níjọ́ míì tó já sí pé a máa ń pè ní àmúlẹ̀ tí máa ń mú aláboyún nígbà mìíràn so bóyí tí ṣe máa ń wáyé ọ̀tọ̀ọ̀tọ̀ ní bọ́mọ tí wáyé ọ̀tọ̀ọ̀tọ̀ bóbìnrin tí lóyún ọ̀tọ̀ọ̀tọ̀ ṣùgbọ́n àkàgbà pé inú àpò la ọmọ iná ni ọmọ máa ń gbé lára yẹ.
Tabadẹ wà nínú oyún bẹ́ẹ̀ yẹn wọ́n máa ń ṣe scan tó ẹ̀mẹ́rin láti lè mọ̀ bóyá bó lọmọ ẹ ṣe wà báwo ló ṣe wọ́n máa ń ní kán lọ ṣe VFC fún àyẹ̀wò ẹ̀jẹ̀ wọ́n á ṣe blood group wọ́n á ṣe urine test tó ti yé ẹni tó bá ní òdìmá tí mo rí pé a ti treat ẹ̀ tí ò dẹ̀ change máa refer rẹ̀ sí hospital torí yẹn lè máa ní convulsion tó bá ń bímọ lọ́wọ́.
Ọ̀pọ̀ nínú èyí tí àwọn orthodox doctor àti orthodox nurse tí wọ́n máa ń mú wá nínú àwọn ọ̀rọ̀ gẹ́gẹ́ bí àwọn ti ṣe kọ́ lẹ́kọ̀ọ́ wípé bí ọmọ bá dàbù kò sí nǹkan míì tí àwọn ó ṣe sí ju pé láti ṣèfù ọmọ àti ìyá ẹ̀ àfi káwọn separation tàbí ọmọ jókòó ṣùgbọ́n lọ́dọ̀ àwa ti ìbílẹ̀ a ní àwọn ọgbọ́n tí à ń lò tó fi já sí wípé bọ́mọ bá dàbù tọmọ bá jókòó a ní àwọn tí à ń lò tí àwọn bàbá wa fi lé wa lọ́wọ́ tọ́já sí wípé irú ọmọ bẹ́ẹ̀ yóò sì wáyé pẹ̀lú rọrùn láì ní ṣe operation fúnrú obìnrin bẹ́ẹ̀.
àwọn nǹkan tí torí àwọn ń lọ sáwọn seminars àwọn nǹkan tí gọ́ọ̀mẹ̀ntì sọ pé a gbọ́dọ̀ ṣe àwọn ò kì í ṣe a kì í kọjá àyè wa.
nítorí bá fi wá lè mú ojú ara obìnrin tó ti gba ọwọ́ márààrún láti pé kí ọmọ ó jáde tí ọmọ ò bá wá jáde ó ti ní àkùdé díẹ̀díẹ̀ tí ẹ̀yin elélébo ń pè ní delay status. So kí ni tí wọ́n ń fà á ìlókù tí a máa wá wò láti máa wo surroundings ojú ara ìyá tí ó fẹ́ bí ọmọ sáyé tí a bá ti wá rí pé kò sí ìdínà kankan bẹ̀ tí a sì rí wípé kó gbin bá a bá ti rí orí ọmọ ó ti ń bọ̀ wá tò sínú a máa wá lo àwọn tọ́jẹmọ́ ẹ̀rọ tí a ó máa fi clean ojú ara arábìnrin yìí tí yóò fi lè já sí ìrọ̀rùn kí ọmọ kó wá sí ilé ayé.
Need someone to talk to them about their mental health, about their child health.
Today in our community, we are conducting some medical screening. So our mission is actually to improve the knowledge and perception of the society on maternal and child health.
I think something that is very lost in today's community is lack of health information and health education.
The love for humanity, the love for continuity, the love for life is what is motivating this.
We are basically concerned about the health of the mothers and the children to reduce the mortality rates, to basically help them live healthy and have a wonderful life. Everybody knows what family planning is all about, but they don't really know the methods.
Most people keep ignorant of their hearts, so we are going to enlighten them, educate them.
Postpartum depression is one of those mental health issues that is not well spoken of in Nigeria and in this community. In this part of the world, not everybody has access to quality health care. So we're able to talk to different women and get information and data in which we're going to evaluate and see how that plays out in this area, in this community.
When we gave some women the souvenirs that were available, they were really happy. One particular woman, she was like, she even prayed for us. It's a nice thing to be able to like give back to the community and all of that, because there are so many people that like need a lot of things, especially with the economy and everything.
It's a great opportunity to have such an initiative as this today, because from the results we've seen from the outreach, it's shown that yes, this outreach was very expedient and very essential.
In my opinion, actually, I feel like we actually have done a great job so far.
This initiative showcases our unwavering belief to improve the health of mother and children by providing quality health care and providing them with enough information that will help improve their quality of life.
This is the beginning of those women being able to identify that they have to take care of their body, of their babies, and also the people living around them.
Healthy child, happy mother.
Ìlera wa àti àwọn ọmọ wa ló ṣe pàtàkì jùlọ.
and good afternoon, and welcome to the second part of this program. We'll be continuing off with a presentation, an abstract presentation on the title "Leveraging the Role of Community-Based Birth Attendants for Continued Maternal Care Provision and Reduction of Maternal Mortality in Southwest Nigeria." I hope that we are energized to learn and to rub minds together. Thank you so much.
Good afternoon, everyone. My name is Adekemi Vincent, and I'm the Senior Program Officer for Safer Hands Health Initiative. So we've all been talking since, and I would still like to introduce Safer Hands to us. We're a youth-led, community-based, not-for-profit, non-governmental organization in Nigeria, and our focus is on increasing access to basic primary, maternal, and child healthcare services in underserved communities in Nigeria. And also, we want to ensure that every pregnancy undergoes a safe delivery that is devoid of common complications. Also, how do we do this? We do this through continuous education, training, and empowerment of frontline, rural, and community healthcare providers. We also involve pregnant women and other stakeholders in this. So what is our background? What led us to focus on this part of health? It's as a result of the knock-on effects it's as a result of the knock-on effect of COVID-19, which led to a migration of a lot of our healthcare professionals, leading a lot of women to patronize all these community-based birth attendants. So then, what are we going to do? Because we found out that for every 10 women who give birth, we have 7 of them going to this community birth attendants. Who are these community birth attendants? These are people who are sometimes semi-skilled, sometimes not skilled, who take care of these pregnant women. And we try to avoid, we found out that because of this increased patronage, it sometimes leads to more complications than it is necessary. So that is why we decided to focus our attention on these community birth attendants, because we found out that these women sometimes feel more comfortable with them because they are in their environment. So these community birth attendants, who are they? They are the people who are there when the health professionals are not there. They are always there. They also provide reproductive services. They provide maternal and newborn care to a certain degree to these women. And so that is why these women go to them continually. But then, how do we maximize this set of people? How do we maximize them? Because there are a lot, and we see a lot of women still going to them, despite the fact that in some cases there are healthcare facilities available to them. What we decided to do is to train these community birth attendants on safe practices for childbirth, for maternal care. We train them. So we go to their communities. How do we reach them? We largely focus on the primary healthcare centers around them. When we go to these primary healthcare centers, they link us up with them, and we go to them. We communicate with them. We let them know these are the practices that should take place when you are delivering a woman. Also, we encourage them to refer when you have a case that you see that you cannot handle, refer these women to places where they can be well taken care of. That does not mean you do not know what you are doing. It just means you care for these people and you love them. So, and the result of this is that we created a program called the Training the Traditional and Community Birth Attendants. So this program, we engage them, we equip them, and that is where our birthing kits come in. We give them this sterile birthing kits and let them know, okay, these are the contents of this birthing kit. They are a one-time use only. You don't have to reuse them, because when you use them once, you protect yourself and you also protect the women who come to you. Also, we provide supportive supervision with them and also link them. Those who are not yet linked to the primary health centers or to the general hospitals around them, we link them up so that it's easy for them to refer, because sometimes some of them are afraid to refer. When they say, oh, if I refer, they will say, where is the nurse that brought you here? They fear. But when we link them up, once they see a little complication that they know, I can't handle this, they easily refer. They are confident enough to refer these women to these areas. Also, we make sure that we work with the existing primary healthcare structures. For example, the Lagos State Primary Healthcare Board. We also work with the Lagos State Tradomedical Board and other people, local governments. We even work with obas and chiefs like that in those areas. We let them know the reason why we are there, and they give us their support. And what has been the results of our efforts so far? Since 2020, we have been able to train about 260 community birth attendants. Out of these 260, we found out that about 38% of them are traditional birth attendants. We have about 11% of them being community-based birth attendants, and about just 1% of them being nursing officers. So we can see the gap that is there, and that is the reason why it is important for us to continue our training with them. We regularly contact them so that we know how, do you have any problems anywhere? Where do you need help? So that we can render that help to them in whatever way we can. And so now we have been able to reach about 12,430 women through these community birth attendants. Through these our programs, we've been able to reach them. And also we've been able to reach about 30 communities with our programs. So what we now need now is the public and private partnership. We want them, because sometimes we might want to have these trainings and then the things we need to use are not available. We do not have the proper documentation. Sometimes they'll ask you, where is the authorization for you to come and do this thing here? Who sent you here? Did you come here to monitor us? Are you here to come and spy on us? But when we have support from both public and private, then these people know that yes, we are bringing something good to them and they will respond to us more positively. So what is my conclusion with this? My conclusion is that community birth attendants their roles cannot be underemphasized. They are very, very important. What we just need to do is to cooperate with them so that we will reduce the rate of maternal deaths in Nigeria. Thank you.
Thank you so much for that wonderful presentation. I hope that we are taking notes. Coming up next, we have a presentation by Valentina Marinze. Valentina Marinze is a dedicated pharmacist with over 6 years experience across the medical marketing, community, and industrial pharmacy sector. She graduated from the University of Lagos with a distinction, and she's the current manager of Ethipharm in Nigeria. Her passion for the well-being of the Nigerian people is evident in her work ethic, as she strives for a nation where health is a priority. Beyond her professional pursuits, she enjoys expressing herself through writing and painting in her free time. Her deep love for God is a guiding force in both her personal and professional life. Kindly welcome Fam Marinze Valentina. Thank you so much.
Good afternoon, ladies and gentlemen. So just a few minutes so my slides come up. It's titled Ethifarm Slide Presentation. Yes, that's me. Apologies. I have a few minutes, so I like to time myself so I don't take up much of the time. Hey, I bring you greetings from Ethifarm, and like I said, my name is Valentina Marinze. I'm a pharmacist. I currently work as the country manager for Ethifarm in Nigeria. And I want to share a story with everyone present here. And the story is my perspective. There is always two sides to a story. So this is my side of the story. My time has just been shortened of no fault of mine. Okay, welcome. So I'll be discussing the current state and challenges of importation for maternal health medicines and supply, the Ethifarm perspective. This story is relevant because, like our keynote speaker has said, our maternal mortality ratio is still nothing to write home about. When we put it side by side, the SDG goal for 2030, we are still very, very far behind. So I would crave your indulgence to participate. The outline might seem, changing it from my laptop, the outline might seem long, but it's just short. I just want to tell you who we are at Ethifarm. A brief on the maternal health in Nigeria. The keynote speaker has already done enough justice to that. Where we as Ethifarm stand in providing maternal health medicines in Nigeria and across the world, the impact so far, some challenges and the implications these challenges have, and I would be giving a charge. So just a brief presentation. So Ethifarm, our mission is to improve patients' life by providing essential medications with a focus on hospital care, central nervous system, and internal medicine. We also have a mission to provide positive impact to society and the environment at large. We are a leading global mid-sized pharmaceutical company that manufactures and provides essential drugs with profitable growth. Emphasis is on essential drug. Whatever medication is considered essential, we like to be at the forefront. At Ethifarm, we are committed to making a difference in patients' lives and to the communities that we serve. Our slogan is Beyond Medicines, Lives, because to us, lives matter more. And so because of that, we strive to comply with the highest quality standards and regulations, and we have proven experiences and track records with several regulatory agencies. We also have been recognized by the Lucy 26,000 label, which we obtained in 2021 for sustainability and environmental action plan. We are very, very big on CSR. So sorry, I'm clicking for my laptop and I forget that I have to change that. We strive to put quality in all we do, and we put our patients first. So we ensure our medicines are safe and effective, and we comply with health authorities in whatever countries we find ourselves in. Our employees are competent and accountable, and we strive to continue improve. So maternal health in Nigeria, I'll just breeze through because the keynote speaker has done a good job on that. In the 2020 report, the trends between 2000 and 2020, it showed that nearly 28.5% of global maternal deaths happen in Nigeria. It also reported that our maternal mortality ratio is 10,047 per 100,000 births. Leading direct causes maternal mortality in Nigeria include hypertensive disorders in pregnancy and childbirth, obstetric hemorrhage, and pregnancy-related infection. I would like to say the Nigerian government have put a strong foot forward trying to reduce maternal mortality in Nigeria. We can see this in their political will, in their support and implementation of the ending preventable maternal mortality, and the maternal and neonatal health priorities being outlined in several national strategies, such as the National Health Act, the National Guideline for Maternal and Perinatal Death Surveillance and Response, National Health Policy, National Reproductive Health Policy, just to mention a few. And then I would not take lightly what NAFDAC has been doing in making sure that safe and effective medications are in circulation in the country. It's one thing to have the medication, is another thing for the medications to actually be effective. So I would say NAFDAC is doing a good job on that. And we also know that the availability of some of these essential medicines is quite low. So what is the cause? Is it low demand or is it inadequate supply? So where we are at Etifam, what are we doing? We have about 1,700 employees. We have commercial presence in about 68 countries. We have 6 affiliates. We have 4 commercial offices. We have strong distributors. We have all these. And if we take it down to Middle East and Africa, we find that in some countries, Nigeria being one of them, we have presence of distributors and representatives like myself, striving to bring whatever goodwill, whatever products, whatever essential medicines that we have in our factory, in our portfolio, we are striving to bring them into these countries to make life better for our patients and the community that we serve. We also want to lay the right foundations to not just bringing in medications. We also want to do what is necessary to make sure that we are on point in each country that we find ourselves. So we produce high quality critical care medication. All good. Etifam does. We ensure our medicines are there when patients need them. This is also our responsibility. We do that. We bring our full portfolio to help patients in Nigeria. Is why I'm here. We're still trying to do that. And we continue to build our relationship to deliver more in 2024 and beyond. So where then is the challenge that we are facing? I would like to say that despite all the political goodwill, despite everything that the government and NAFDAC has been doing, trying to make sure that importation and registration of products is easy, trying to make sure that new companies like mine find it easy to do business in Nigeria, unfortunately, I would say there are still some bottlenecks. I would applaud what is going on with the restrictions and the controls put in place to ensure counterfeit medications do not come in. But this has put a strain on the importation of medications and essential medications that maternal health care would need. These strains are necessary, but there is a delicate balance between that control and between tightening a grip on supply. It's so difficult to get things into Nigeria. There are a lot of timelines, there are a lot of submissions, there are a lot of bottlenecks, there are a lot of bureaucracy. We don't even know what timeline we should expect an import permit to come out. We are told 2 weeks. We start the application and then we end up getting the import permit in 3 months. So that really puts a strain on the supply. This is what we have to offer: quality, supply and availability, making sure that we can do all these. But because we're a company that strives to follow whatever rules and regulations we see in place, we cannot jump overboard and decide to bring them in without going through the right procedures. So this impacts supply. So when we are talking about low availability of maternal health products, there is a high demand. But what is happening with the supply? I would say we are not being supported to the best that I believe we can be supported with in order to bring in these products. But I know that we are getting to a level where we should be able to do that. And for that, I would applaud the government and NAFDAC for doing their best. But I would say we are still not there yet. Finally, I would like to call to action all medical providers here to ensure quality, safe, and effective products approved only by NAFDAC are used in your facility to ensure effective and safe medications. I would like to implore policymakers to ensure favorable policies for the importation of essential medicines for maternal and neonatal health are put in place. And priority should be given to these products. And in implementing policies, in creating policies rather, implementation, what are the steps, the nitty-gritties? This should take a very, very critical part in the planning and in the creation of policies. Because a policy might be created so beautifully, but the steps, the tiny details might be the cause of the bottleneck. And to the general public, I would like to employ everyone to work with the government and other state parastatals to sanitize the process of availability of maternal health products. By that, I mean do not patronize products that are not registered and approved by NAFDAC for use in country. Thank you very much. I'll be taking comments. I don't know if there are comments or questions I can take before I take my seat. I still have a minute to go.
Thank you so much from Marinze. So I want to ask a question. From ATFARM perspective, we know that the cost of medication and supplies in the country is over the roof. And do you think, or is there anything going on between pharma and the government in terms of clearing imported drugs that will help to reduce the cost of medication, essential drugs for maternal health care?
Thank you for your question. I was actually trying to walk on eggshells around that, but since you asked, from our manufacturing sites to our distributors, our prices are very friendly. But because these are products coming into a country, we have to pay import duties, we have to pay taxes, which is why I urged in a blanket statement policymakers to make policies that are favorable for us and prioritize these medications. Now, if coming from us, the prices are good, I can tell you that on some of our products, I'll just give you an example. An arbitrary example is not real. We sell a product for $1. By the time it goes to clearance and everything it has to go through in Nigeria, that product becomes $2. Now, we are doing this because everybody is doing it. It's the law of the land. We have to respect it. But if the government, the policymakers can make a case for maternal and neonatal health products and insist that for these products that are used for this delicate number of people, because we want to get to our SDG goals by 2030, let us bring down this price for clearing, for taxes, for importation. The price would be cheaper than what you see in the market. But we are still paying some sort of taxes that influence the final price in markets. Well, we try to make moves to the government, but we also have to be very, very careful because we don't want to be seen as trying to curry favor instead of doing the right things. You understand? So there is only so much we can do when we are speaking to the government. We can offer partnership, we can offer support, we can offer some free packs to reduce the cost, but there's still a limit to how far we can go.
Thank you so much, Arinze, for that wonderful presentation. And it has cordially ushered us into the second theme, which is synergy for local production and importation for maternal health medicines and supplies. This subtheme would be discussed more on by our panelists, and I'm going to call on them now briefly. We have the first one, ACPN chairman, who is a phenomenal leader with a background of consecutive involvement in impactful projects. We have Oladibolu Adewale. We have the chairman for NAM Lagos. She's an excellent professor with more than a decade experience catering for primary healthcare activities management in Lagos. CNO Christiana Adeboboye. And we have a representative of Nigerian Association of Industrial Pharmacists. We also have the Director General of NAFDAC in the person of Professor Mojisola C. Adeyeye. She's currently the Director General of National Agency for Food and Drug Administration and Control. Professor Adeyeye graduated from University of Nigeria, Nsukka, Nigeria, with a B.Pharm degree in 1976. She obtained her PhD from the University of Georgia, Athens, GA, in industrial pharmacy. And prior to assuming the position of Director General of NAFDAC, she was a professor of pharmaceutical marketing. And drug evaluation for 30 years in the USA. She retired as Professor Emeritus from Roosevelt University, College of Pharmacy, Chicago, Illinois, USA. She has mentored 15 PhD and MS candidates and co-advised 18 graduate students as research committee member. Now moderating this panel session, we have Dr. Lillian Igweze, who is the founder and lead educator at Pregify. Pregify is a fast-growing healthcare startup offering mobile antenatal, maternal, and childcare services to career women and young professionals. So would give the panelists a few minutes to come up to the stage for the panel session. Thank you.
Good afternoon, ladies and gentlemen. Yeah, I am Dr. Ifnaya Lillian Igweze, the co-founder and CEO of Pregify, and I'm moderating this session today. Okay, this panel will be discussing the synergy for local production and importation for maternal health, medicines, and supply. And we know that more than 60% of the essential maternal care medication that we use in Nigeria is being imported. So this session is quite an interesting one and something that concerns all of us because importation impacts on a lot of factors in the pharmaceutical industry, from price to availability and the rest. So joining me on this panel already here is representative of Director General of NAFDAC. She's ably represented by Director of Drug Registration and Regulatory Affairs. Okay, please excuse me, your updates. Okay, so Justin is here to represent the Director General of NAFDAC. Please, can you give a round of applause? Also, on the panel, if you're around, is the National Chairman, Association of Community Pharmacists of Nigeria, ACPN, from Adewale Oladibolu. Also is Chairman, National Association of Nigerian Nurses and Midwives, NANM, Lagos State, Mrs. Christiana Adeboboye. All right, we are going to do this. Marinze, where are you? Oh, she's gone. Okay, from Justina. Nice having you on the panel, Justin. Nice having you on the panel. Please just briefly introduce yourself to the audience.
So good afternoon, everybody. My name is Justin Isagoni. I'm an assistant director with the National Agency for Food, Drug Administration and Control. I'm currently in charge of Nigerian Drug Unit of the Drug Registration and Regulatory Affairs, and I'm here to represent the DG NAFDAC in this panel session. Thank you.
Yeah, thank you so much for honoring our invitation. Okay, the first conversation I want us to have is about the importation of drugs. With the current trend going on in the country on maternal medicine, maternal health care medicine and supply, would you say we have more locally produced drugs or more imported drugs and supplies? What's the balance like?
I think the balance is not peculiar to maternal health products, really, and is actually also not peculiar to Nigeria. Across the sub-Saharan Africa, actually, it's a known trend. We have more importation of health products than we have for locally manufactured products. And that's one of the reasons why, in line with the 74th Assembly of the World Health Organization, the agency has been looking towards pushing and promoting in-house, in-country, local manufacture of health products, especially essential medicines like Marinze said, for maternal and child health care.
Okay, thank you so much for that. So it's not a Nigerian problem to say. Interesting to know, maybe a consolation. Okay, so you mentioned that the government is encouraging local production. We saw what happened one day when GSK left, you know, a kind of things went really bad from the medications they had in the market, even until now. So do you think that encouraging more local production in the country will help to increase the availability of these medicines and supplies?
Okay, to answer that question, I want us to cast our minds back to what happened in 2020. Nobody foresaw COVID. And then we were hit with this pandemic. And in the world's panic, every country started to hold their own. Nobody wanted to release whatever they were supplying you, even at whatever cost you were ready to pay. And so you realize that a crucial factor for availability is your own homegrown. The world is gradually coming to that point, not only for healthcare, for almost everything. I'm sure that if we pay attention to media, we can see the world is gradually shouting about food security as well. We need homegrown to enhance availability and accessibility. Accessibility is, oh, it is there, but availability of it, that is it being there, is going to be hinged in future years to come on our capacity to develop homegrown. So yes, I do believe that enhancing local manufacture of our products, especially those that are essential to us, would enhance availability and on the long run, affordability.
Yeah, thank you so much. I love that you mentioned what happened in 2020 because, to be honest, this is 4 years now, and it seems like everyone is relaxing again, and we don't know when the next pandemic is going to come. So building capacity now for the future is actually encouraged. Yeah, thank you so much for that. Okay, looking at the balance between locally imported and produced pharmaceutical drugs and supplies and importation, of course. I know that at least for now, we will still be importing drugs, while we're encouraging local production. How do you see that balance? How do you foresee it? How is it going to be?
Okay, so we're looking at balance and synergy to make local production and importation of our maternal health products. How do we achieve that balance? That's the question you're asking. Okay, there are so many players in this field. That's the sincere truth. I wish we had a complete panel. It would have given us a balanced view from the industry, from the government, and even in the government, there are different players in the government. I mean, from Marise talked about import duties and all of that. Unfortunately, I can't speak to that. I wish we had somebody from customs to speak to that, you know? So the real truth is it's going to take all our players together in one room, looking at it critically, and then seeing where we can concede based on how essential these medicines are. For NAFDAC, what we have done, because my DG has been in the forefront since she came in 2018 on improving local manufacture. She's been pushing for it. We've had a lot of policies developed within 2018 and now. Some policies, if industry people were here, they will corroborate. We have a policy called the 5+5 policy, where we have, within a span of time, we have a list of products. We've looked at the capacity of our pharma industry in Nigeria, and we realize that we can actually produce these things in-house. And we're given a space of time for certain products. Some maternal products are on that list, so that those importing know that after a certain period, they can no longer renew their license. They have to look for how to move that product to be produced here. Now, we've also tried to upskill in the agency to make sure that registration processes move as seamless as possible. If you listen to the last speaker, she talked about the fact that, oh, you say something is 2 weeks, in 3 months, you're still chasing it around. So a lot of our processes that used to be manual have gone full electronic. That in itself has presented some challenges which are fine-tuning along the way, because people are used to manual and don't want to easily migrate to electronic. But that way, it makes it easy for our 3 months to be 3 months, because you can see it, I can see it, you can see it, everybody can see it. Another way we've tried to ensure that access is not impeded is in putting that balance between, we realize that yes, our pharma industry is still coming up, and these medicines are essential. They are not going to wait for pharma industry to come up, because these are lives. Every pack is a life. It's not just a commodity. This is a life you're looking at. So we have what we call a ceiling list. So the ceiling list allows the importation of certain classes of products while we are building. So no additional importation is coming beyond that. That still goes on while pharma is coming up. So we have so many things like that in the pipeline, but the general balance, like she says, there has to be a lot of government intervention, government backup, and all the key players need to come on board, on this issue of essential.
Yes, it's actually multifactorial, and it's not just a NAFDAC thing. It's not a NAFDAC thing. And I love the fact that NAFDAC processes are being automated now, because it's one of the things that, even for, let me deviate a little, food production, they tell you, the process, once you tell somebody, you have to enable that, the process is used to be quite cumbersome. So I'm glad that it's easy enough now. And digitization takes time, especially in Nigeria. It's going to take time for people, even in the hospital, when we start migrating from writing in the folder to using EMR. People come and say, the network is poor, it's wasting our time, isn't it? But gradually everyone is, adapting to it. So thank you so much. And before we go to the final question, I want to ask something specific to NAFDAC. Okay, so I asked from Marenze about drug costs and the factors influencing that, but we based our discussion then on importation duties, tax, and then I want to know if NAFDAC registration and processes are also a factor to this, talking about the price, the cost of those processes. Do you think is also impacting the price of medication for this people?
Okay, so you're asking if NAFDAC's tariff for registration is impacting the price of products.
Yeah, all the activity big pharma needs to do with NAFDAC. Is it, because I'm not a so, but I know they do registration, they do testing, approvals, the pricing that is attached or what's do you think would they be whispering in their offices that NAFDAC process is too expensive and is affecting us?
Okay, they really don't need to whisper in their offices to answer your question. Now, I need you to understand that NAFDAC is a government agency. No government agency fixes their prices. There is a process in law and in government how it's done. So, and one of the ways is done when tariff is supposed to be modified is a series of town hall meetings where the key stakeholders, the organizations and the individual companies are called into an open town hall. It's very similar to what you see in the National Assembly, where they tell you, oh, you're trying to push a bill. So first reading, second reading, third reading, and then it's passed. It's very similar. It's something like that. So there are negotiations that go on to meet that. The pricing for imported products is way more than local products, and that is not surprising because we're encouraging local manufacture. Local manufacture prices haven't altered, they barely alter. I'm the head of Nigerian drugs, and I can tell you, yes, maybe imported will complain, the disparity is a lot, but like I said, NAFDAC doesn't fix prices. And so if those tariffs are going to change, the same procedures will go, all over again. So it's not something to whisper in the office. There are steps written clearly in law how those things are generated. Our own responsibility is to follow whatever tariff is given to us by the government, because those tariffs are gazetted in the law. Whatever tariff is put there after those sequences will follow. But as my like I said earlier, my DG's concern in promoting local manufacture, she has always guarded whatever pricing for local man to encourage our own homegrown.
Yeah, thank you so much for that. Of course, we need to encourage local production, also, encouraging that, because those of us that are still here, it's not because we don't know the route to the airport, but we are here to, help to improve. So we should be able to do everything possible to get our stuff being produced here. Okay, so before we close the panel, we know what the current economic situation is in the country. We have inflation, poor electricity, insecurity, and all that. So what do you think is the greatest obstacles affecting local production and supplies? What do you think that if they say, oh, that the governor of Lagos State, or let's say the Minister of Health, is listening to us now, and they're about to implement whatever we request for here now. What do you think that you identify as the major obstacle facing pharmaceutical production of essential maternal health drugs and supplies, and what do you think is the way forward?
That question is better answered by industry. Because it's the person in the industry that is manufacturing that can actually tell you what their greatest challenges are. I don't think I'm the right person to speak about that. But I do know that I happened to be in a meeting where we were discussing the local manufacture of caffeine citrate for treatment of neonatal apnea some years back. And I did say there that the key players and the healthcare industry as a whole, we need to come together. We need to actually map out what our challenges are. Because what you perceive as challenges may not be the actual challenges or the actual obstacles faced by those in the field. So we need to map out what our exact challenges are, and we need to map out how we want to advocate. If we're sincere, a lot of the things are things that are some of the things are things that are out of our control and need governmental intervention. Governmental intervention comes as a result of solid advocacy. But for you to advocate, you need to have your points, on hand. You need to know what you are advocating for, and how you know if your advocacy has worked is when you know what you are asking for. So we need to come together as healthcare, irrespective of professional orientation. Realize that maternal health is critical to the nation at large. Make our research, know where our obstacles are, and outline how we want to go about advocating for governmental intervention regarding it. That's my own thought.
Yeah, thank you so much for attempting to do justice to that from your own experience. And I quite agree with you that some of these factors are beyond us. It's beyond us. It needs government intervention. So it's a kind of a collaborative effort from the professionals, industrial farmer, clinical practitioners, nurses, everyone, all of us, non-governmental organization, bring your data, let me bring my data, let's have this in numbers, and then present it to the government. And I believe it's going to help because, to be honest with you, at Predify, because we directly work with mothers from several places, because it's online, so I won't say just Lagos State or it's Ondo State or Anambra State or UK or Canada, So you tend to see that sometimes some of the complications that you see during pregnancy or probably after birth, you see these women coming down with, let's say, an episode that the stitches has broken down. And when you review everything they did, it was not their fault. Or a post-cesarean section wound that's broken down. And if you check out, you see that it's probably linked to the antibiotics that was given. How strong it is, was it effective, and all that. So I think it's something that is not just about, having this panel and then we go home and wait for another, event. It's time for us to, everyone comes together to bring in their experiences and everything they have seen, and be able to raise one voice towards this. And so I'm calling on all stakeholders here as we are closing this panel, please. We need to have one voice. We need to, whether you're a non-profit or you are for profits, we need to have one voice. We need to also start sharing our stories. I see, let me use fintech as an example. When things happen, you see financial experts, they analyze CBN. Once CBN says something, you see them analyzing it. My mentor is a fintech person. You see them talking about it, breaking it down for the common citizens to know exactly what this policy says in a layman's, but you don't see it in health mostly. You don't see it in health. So it's time for us to, when WHO says something, United Nations publish something, Minister of Health publish something, whether it's locally or internationally, let's break it down. Let's talk about it, and promote it. And I'll tell you that if we start doing this, our voices will be heard, because I know someone that just by breaking down a CBN policy, he was invited to Channel Station to come and talk about it. Just by tweeting it, he was on Channel. So imagine when you break down something like that and it goes viral, and then you have the opportunity to be on channels or AIT, to talk about it. It's going to attract more audience. So let's come together, use the power of social media, newspapers, articles, journals, and anything, to talk about our everyday experiences, so that people can see it and invite you to talk on a larger forum to reach larger audience and attract better, higher stakeholders to act on it. So thank you so much, Pan Justin, for joining me on the panel, and thank you, everyone.
Dr. Kemi would like to ask a question. She's joining us virtually. So Dr. Kemi, please kindly unmute yourself and ask the question for the panelists. Thank you.
Good afternoon, everybody. Good afternoon to all of our speakers and participants. I'm sorry I'm unable to. Can you hear me, please?
Yes.
Okay, yeah. So I'm sorry I'm unable to join physically, and I'm unable to turn on my video at the moment. I'm kind of in transit. But thank you to our panelists, the representative of the DG of NAFDAC. Thank you for turning up for us. And like you said, it was unfortunate that the other people we hope to have on this panel are not available. It would have given us different perspectives to the different things to be discussed. But my question is, so at SHI, we are a non-profit, non-governmental organization, and most of our interventions, like was earlier discussed, is we have some materials that we give to pregnant women and traditional birth attendants or community birth attendants. We donate these things also even to PHCs and other healthcare facilities. And we've been getting these things or these medical supplies, let me put it in quote and unquote, medical supplies since 2017 when we started in SHI. And we usually get them from the Betting Kit Foundation, Australia. So they are betting kits, and it contains, Macintosh, gloves, soaps, surgical blade, those petty things that you need to take a delivery at a go. And I realized that about 2022, I just recently started getting calls from Custom and NAFDAC saying that, our importation has been impounded because NAFDAC is saying we don't have clearance for it, or the port people are saying we don't have clearance for it. And I'm like, I've been importing the same thing, like we have been receiving the same shipments since 2017, and I've never heard of this before. Why this sudden change? Anyways, towards the end of 2021, 2022, it was a struggle trying to, get that clearance from NAFDAC. We had to keep going to the NAFDAC office at different points. Eventually, we're paying huge sum of money to get those shipments, cleared. And at some point, we were discussing with the partners that used to supply us with those betting kits, that's the BKFA, and they were asking about the possibility of, okay, so what if you can produce these things in Nigeria instead of, because it's seeming like sending it to you from here is costing you a lot. What if you can produce it in Nigeria or do it in Nigeria and we send you the money instead? And by the time I did the costing, then it was actually more expensive. And by the time I sent the costing to them, they were like, no, that is way cheaper to be done here. But at the end of the day, it still comes out the same thing. By the time you pay custom, you pay NAFDAC, you pay everybody, it's still a lot of money to go. So I just wanted to ask that, are there what's the English word now? Are there means through which, we are not for profit, it's different for people that are bringing in these things to sell them. we are not selling them, we are taking them to the community. And I'm sure it's not just us having this problem. Some other organizations too might be facing this issue. Are there some consensus for organizations that are not for profit, in clearing such supplies that we know that they're not selling them or making any form of profit for them from the governmental organizations or agencies? Because they're mostly the ones that give the issue. Tomorrow I can get a bill from my program officer saying, oh, we have these shipments, but they say custom is holding it, or port is holding it, or NAFDAC is holding it. Okay, so what's the next thing? They say, come and pay. They send us bill and it's running into hundreds of thousands. And I'm not kidding. And it's becoming for me, it's becoming a serious problem. So is there any consensus for not-profit organization? Is there a way we can go about this that we don't pay, or we pay the barest minimum or something? Thank you.
Okay, thank you for your question, Dr. Kemi. And I find your question a bit funny because I am aware that not-for-profit organizations like at least I can speak for Red Cross. There is something you are supposed to collect from the Ministry of Finance that should not allow you pay. It's a Ministry of Finance and Customs issue. So you may need to liaise with somebody in Red Cross. I am aware that there's a document or something like that that gives an exclusion if it's a donated item. For NAFDAC, we have a permit for donated items. Okay, I'm not on that desk, but there is a permit for donated items. So the question is, did you approach NAFDAC for it as a donated item or for it as a service drug, in which case you are not bringing commercial quantities, large quantities? So you see, the problem is the kind of permit you request is what will determine what you get. But I do know because I had discussed with somebody in Red Cross at a point in time, and he says that there's a document they get from Ministry of Finance that shows that they are not profit, so that they are not levied by customs. I really don't know much about that. So I would just advise that for that, just reach out to another not-for-profit organization. Red Cross, I'm very certain about. Please reach out and ask them about that for customs end. So somebody there should have told you about it. But for NAFDAC, we do have a permit for donated items. Because one of the challenges we have is abuse of systems. So we were running that permit for a long time. So people just come, especially people from diaspora, they say they are bringing in something to share in their village. And you find out that the consignment comes, all of them are expired drugs. Like Famarize said, there are many sides to a story. We've had a lot of abuse with it. So it's not a permit you would easily hear about. So I would advise that if you could send somebody to Drug Registration and Regulation to speak to the director and be clear that it is a donated item. However, the clearance fees is not what NAFDAC does. That's customs. But the only hint I can give you is kindly liaise with somebody in another I've heard that before. What the document is, I cannot tell you, but the person has told me before that there's something before, and it's done prior to every shipment. So they collect it and their custom fees are waived. Okay, but for NAFDAC, you need to send somebody to clearly articulate that it's a donated item. That's all I can say about that. Aside from that, except I know what the person asked for or the process that was initiated, I may not be able to speak clearly on why you have that bottleneck. But we do have a permit for donated items, and they need to be certain that they are actually donated items. Because like I said, we've had a lot of issues with abuse of such things created for that. So you now see every Tom, Dick, and Harry is trying to come in to, manipulate the process for their own use. So that's just it. I hope I've answered your question, Dr. Kemi. Hello?
Yes, ma. Yes, ma. I was trying to unmute myself. Yes, ma, you did. Thank you very much. And even though I'm not there physically, some of my program officers would meet up with you to, get your email address and your contact for further discussion on this. I think we'll just like to go through that route. Thank you very much, ma.
Thank you very much, ma'am. I'm Mrs. Akinremi Rashidat, Deputy Director Nursing Officer from Health Authority, Ota. Thank you. My question is, those that hawk on Facebook, is their products seen by the NAFDAC, or how far it is? Because you see so many, they will say pineapple, they will say you need to spleen so that you can get a reduction in the price of the drug they are selling, especially for this DM or cancer. You can see them on the Facebook. What is NAFDAC doing about it? You can't hear me on Facebook or social media. You will see some people hawking drugs that is for DM, diabetes mellitus, or all sort of drugs that you can buy, you can use. I say, how far is NAFDAC regulating that? Are you okay now, ma? Thank you.
So you're talking of those adverts. Okay. All right. So, well, we are also constrained by manpower like everybody else. We do not allow for such adverts. We have advert control, we have enforcement, we have post-market surveillance, and they go around, they try to track those companies. If you watch those adverts well, they're usually no face, no address, no nothing. We actually try to track them. However, you realize that you find that with, you don't find that with ethical products, because no ethical product can do that by law, by international law. Do you understand? We don't have, so we actually have advert control. Look at that. In fact, if you get to their office, they have screens up, and they try to track those people. Most of those addresses we see are fake, but we do the best we can. And when we get them down, we pull them down. We're currently trying to see if we can foster a collaboration with NCC, because it's not our talk. We don't control the internet space. The National Communication Commission does that. So we're trying to see if we can broker some communication with them and have something legally drawn up so that they can take down those things or not permit it. Do you understand me, ma? But if it's something ethical, you will not see it there, I can assure you.
Any other questions? Okay, thank you so much, everyone. And thank you, Fam Justin, for joining.
Thank you so much for the wonderful panel discussion. I'm sure we took one or two things that would be implemented in our different spheres of influence and of work. I would like to again acknowledge our sponsors. We have Ethifam, we have Remedial Health, we have Kensington, we have Mother and Child Health Projects, we have the Lagos State University Sickle Cell Society, and we have Medical Mirror. Thank you so much for your contribution. And our partners, we have, as some of our partners that are here, we have the Value Female Network Africa, we have Medical Women Association of Nigeria, Lagos State Branch, and we have Healthcare Analytics Consults. So without your contribution, without your resources, you would not be here. Then I would like to acknowledge the presence of the chairman of Lagos State Ministry of Health Traditional Medicine Board, Professor Adefule Ositelu. Thank you so much. Thank you so much, Ma, for joining us today. We see you, we thank you. And next up, we have the product presentation from a representative at Remedial in the person of Farm Adegbite Oluwapelumi. He is currently the Business Development Executive at Remedial Health. Oluwapelumi is an innovation enthusiast with a knack for driving change. His journey in the pharmaceutical industry began as a medical representative at Roche, and over time, he transitioned from clinical practice into the digital health sector. Today, his passion lies in propelling innovation in healthcare and other industries, particularly through product-led growth strategies for tech startups and businesses. Beyond his professional interests, he is also a creative photographer and a history buff who loves to explore, collaborate, and make a meaningful impact in the world, one solution at a time. Let's kindly welcome Farm Adegbite Oluwapelumi from Remedial Health.
I mean, I'm not the tallest person in the room, so is this fine or should I just step aside? So I'll be standing on existing protocol. Good afternoon, everyone. Good afternoon, everyone. I'm not used to this. So initially I was told I had about 20 to 25 minutes. But if I take about 20 to 25 minutes, I think I will lose you guys in like the 10th minute. So I'll just make it very, very short. My name is Adegbite Oluwapelumi. I'm a pharmacist and I work as a business development executive with Remedial Health and our subsidiary company, Kensington. What do we do at Remedial Health? We're a health tech organization and we digitize pharmaceutical supply chain in Nigeria. We are currently just 2 years old, but we have our reach in all 36 states in the country currently. But I'm not here to sell you Remedial. I'm not here to sell drugs to you today. Actually here because of this topic, this Maternal Health Summit. And I want to start with a couple of questions. Like I said, 5 to 10 minutes, I'll be back on my seat, please. So how many of us are aware that today is World Malaria Day? Yeah, we are very aware. Okay, how many of us are also aware that over 10% of maternal deaths occur as a result of malaria in pregnancy? If you ask me, I would think if we solve the problem of malaria in pregnancy, we would significantly reduce maternal deaths. So I would like to start by saying that I live in a bubble. And what I mean by that is the fact that I understand the fact that I enjoy certain privileges. I don't want to say we, so I'm trying to speak for myself. You are smiling, Ma. You can relate to the fact that we live in a bubble. I have access to significant healthcare. I have access to the internet. I can come out of this hospital before I turn 2-3 streets. I'll see Health Plus, Med Plus, all the pharmacies lined up. This might seem like it's a norm to you, but it's actually a very big privilege. I would like us to also understand that the fact that I live in a bubble, I understand that even though sometimes it's only 10K that is in my account, I'm still not classified as poor. Now, it might seem like I'm digressing, but just flow with me. Currently, according to the World Bank, about 104 million Nigerians are classified as poor. That's 46% of our population. You might be thinking, oh, I have 5K in my account and maybe part of this. No, you are not in this statistic. The people that are classified as poor, you probably see them when maybe on your way back home and you are maybe not fully aware of their realities. So I'll take you back with a story of where I served. I served in 2021. I tried to work it to Lagos State or Abuja or last. If they give me or your state, I'll collect it. But my plug burnt. Don't ask me how. I ended up getting posted to Bayelsa, but I still had strong head. I said I'm not going to Bayelsa. Initially, I waited for the next stream and I was posted to Delta State. In Delta State, I was exposed to a lot of realities that I would not have been exposed to if NYSC had not thrown me there. When in Delta State, I tried to work my redeployment to Asaba, the central cities, but that did not work out. So I was posted to a place called, hold on, I don't think you have heard of this place. It's called Ubewe, Jesse. And there I was posted to work as a clinical pharmacist at one of the primary healthcare centers. Now, with the money you are managing in your account and how you think you might be experiencing financial difficulties, I was exposed to a lot of realities at Ubewe, where they still live in mud houses, where there was no internet, where you would have to and there are Nigerians too, just like you, just like myself. So at Ubewe, I was working under the hospital management board of Delta State, and there they send medications to each primary healthcare center. And of course, we are begging these people to even come to the hospital. So we have to give out the drugs for free, at least the malaria medication, Now, if you guys there, how many siblings do you have? 2 siblings, 3 siblings? At Ubewe, the average family size, 10 siblings with funny names like God's Grace, London, My God Liveth, America, funny names. And I used to enjoy seeing firstborn, 4 years old, secondborn, 3 years old, thirdborn, 2 years old, fourthborn, 1 year old. And they will pack them and come to the clinic. And you would be thinking, don't these people know about family planning and all of that? But no, that is their reality. You would see young ladies of about 25 years old with 5 children. I'm older than 25. I'm still praying for God to get married. So it opened my eyes to that reality. That reality that when we say 104 million Nigerians are poor, it is not me, it is not you. We are actually very exposed to opportunities. I'm aware that when they say 68 million cases of malaria occur in Nigeria and leads to 194,000 deaths, it is not an exaggeration. So at the clinic where I worked at Ubewe, very close to Sapele, once we started, and we had antenatal clinics almost every day because family planning was not a thing. Everyone was pregnant. Once medication finished in the pharmacy store, there was no place to refer them to. Are we going to be referring someone with 6 children and no meaningful source of livelihood to MedPlus pharmacy? There was no even MedPlus pharmacy. So now the challenge I noticed there was the fact that once the drugs once we ran out of stock in the primary health clinic, which was like almost every 2 weeks, there was no medication for anybody. I remember one time I was on duty and a woman was in labor. Well, we did not have the right drugs to conduct a CS for her. So we continued begging her because that was the only thing we could do. We beg you to push. And that is their reality. I'm taking my time because I want this to sink in, but still 5 to 10 minutes. I'm going to go. So the reality of the people of Ubewe, which is the reality of millions of Nigerians that we might not have been exposed to, is the lack of access to medication. Our remedial health, one thing we hold very dearly is health equity. Health equity says that every Nigerian, if you are living in Banana Island, you live in Lekki, Ikoyi, you live in Abuja. I recently went to Abuja. Really nice place. You are living in a bubble. There are millions of people that live in very remote areas. Remote areas that some of my friends were also posted to. I've not even used up to my 20 minutes initially. Oh, 5 more minutes. Don't worry, I'm on track. Many of my friends were posted to places where they had to take boats, cross, risk their life, wear life jackets, and cross to. What is my point exactly? The pharmaceutical supply chain industry in Nigeria is not Med Plus. It is not Health Plus. Yes, there are big players, but it doesn't revolve around them. That is about like 10 to 20% of the solution we need. The reality is that there are millions of people that are actually dying because they do not have access to buy artemether and lumefantrine, because they do not have access to buy Coartem, because there's no folic acid in a certain drugstore for them to use, and they are dying. You will see someone dying and you will think it's one chronic case of cancer. No, it's just diabetes, no insulin. That is the reality. So if there's one thing I'm going to leave here today, is the fact that we should open our minds to the reality of the millions of Nigerians out there, our brothers, our sisters, our aunties. I've listened to my senior colleagues from Valentina, from Justine of NAFDAC, and a lot of other people, and I've listened to you guys. And I'm very impressed with the efforts being put in place. But we need to do more. When we read stats like 100,000 people die as a result of sub-quality medication or fake medication in Nigeria, you do not really put spaces to those statistics because, of course, you have Med Plus, you have Health Plus. So I'm here to tell you that we, right here, we should play our part in ensuring that a lot of Nigerians, that more Nigerians, every single person, every single child, every single woman, those in Ubewe, those in Ikoyi, those in remote parts of Bayelsa State, and those in VGC, they deserve the same quality of access to medication. So now, with the last 2 minutes I have, I will shamelessly sell remedial health. Our remedial health, we are solving this problem by making sure that every Nigerian, and not just the privileged me and you, or you and I rather, have access to quality medication. There are a lot of challenges involved with it, challenges of logistics, but we have moved further to ensure free delivery to these locations, trying to service pharmacies, hospitals, wholesalers, PPMVs, to make sure that quality medication is actually a reality for every Nigerian and not just the privileged few. I think I've said all I planned to say, and I hope this has left a lasting impact, that whatever solution we are trying to prefer to give out there is not for Lagosians, is not for the privileged few, it's for every Nigerian. Thank you very much.
Thank you so much, Remedial Health, for your brilliant work in improving the lives of every Nigerian. I'd like to call on the next person for her presentation, the fifth abstract for today, titled Advancing Maternal Health by Improving the Menstrual Experience of Young Girls and Women, by Mrs. Nkechi Ibe. Thank you, ma.
Good afternoon, everybody. My name is Nkechi Ibe. I'm the founder and director of Impact Award Foundation and standing on all protocols. I don't need to establish any new one. I'm here to speak on the title, Advancing Maternal Health by Improving the Menstrual Experience of Young Girls and Women. And it's because of our direct dedication to ensure that at an early age, young girls understand what it takes to be a woman. And I'll ask, at what point do you think is the right time to start educating a young girl on, certain issues around pregnancy, sexual and reproductive health? And I will answer, I'm asking and answering myself. And I will answer at the time when she sees her period for the first time. The truth is that for every young girl that sees her period today, she automatically becomes a potential mother unless she decided otherwise. And so therefore, there is need. I remember just a quick story. I saw my period for the first time at the age of 15. And I remember that at that time, all my friends have seen their periods. Like it was almost like everybody's seen their period. I've not seen. So I was worried. So eventually when I saw my own, I was so excited. I have no idea what I was going into. I was excited. And I went home that day and I told my mom, and I was expecting her to be very, very excited, but she just gave me a smile. And the next thing she said in Igbo, I'll use Igbo, she said, now. To be translated, it is now that you start running from men. Ladies and gentlemen, that is the totality of my sexual and reproductive health education. That is where it started and that is where it ended. I have zero, and the mentality is that you have to be scared of the opposite sex. If they touch you, you get pregnant. If you go around them, you get pregnant. Everything you do at that point, you're just afraid of pregnancy. And I didn't learn about anything concerning menstrual health or anything concerning all of this. It's just that going it like that, doing it the way we know it, until I get to I visited my sister who happens to be a nursing student at the University of Nigeria, Enugu campus at that time. I came to her room, and you know how you medical students used to do. You'll be discussing, you not want us to know what you're talking about because you're using big jargons that speaking all these big English. I'm just there looking at them. Immediately I heard menstrual cycle. I said, hey, I want to learn menstrual cycle. And my sister said, you don't know how to. I said, I don't know. Even I was in the university then, no, so imagine. So that day I got a class I never opted for. I thought it was just a simple something. But it ended up being calculations and figuring out, even they are drawing tables. Ha. So, but at the end of the day, I realized that the quality of menstrual health is very important in determining the maternal outcome. We must begin early enough to begin to teach young girls on how to take care of their menstrual health. And that is the commitment of our organization. I am committed to it because I have seen the relationship or the intersection of this. A young girl today is a mother tomorrow. And if she can comfortably take care of herself today, she can comfortably take care of her maternal health. I was 15 many years ago. Today, I'm a mother of 3. If I don't learn, there are certain things that as a woman, we continuously use pad. Even as a maternal health, when you give birth, we use pad. So if we don't know the basics of hygiene, menstrual hygiene, disposal, all of these things, it becomes a very big problem. And that is what we do I can't even see even my glasses. And that is what we do in Impact Award. Keep moving. So that is what we do in Impact Award Foundation. And because of that, we introduced a program called She Needs to Know. It's as simple as that. The title of the program is She Needs to Know. She needs to know every single thing that she's supposed to concerning her body, adolescent age, concerning puberty, concerning relationship talks with the opposite sex, concerning contraceptions, teenage pregnancy. She needs to know. And that is what we go around schools doing at all times, educating them. But in the course of educating them, something came up in one of the schools I visited I visited Eric Moore at Surulere. So after the education, one very bold girl, I can remember her name, Destiny. She's my friend now. She has finished school. So she walked up to me and said, Ma, I like the way you were talking and I like what you said to us. I learned a lot. I'm like, thank you. She said, but all these things you're teaching us hygiene practices. I'm using tissue. My friend there is using wrapper. So how do we take care of our health with all these things you're saying when we are already exposed? She actually used that word, exposed. Okay. I'm almost done. So at the end of the day, I realized that it's not just enough to educate. It's also good for us to create access to those sanitary products. That is why we came up with the girls' period kits. And so while we educate young girls, we also give them period kits that contains pads, sanitary pads, hands, soaps, something that can actually help them, at least for the period of their time in school. they have what they can use to take care of themselves for that time. And it will improve their educational attendance, school attendance, educational performance, and the rest of them. And so therefore, for the period of years that we've worked with, we've spoken to over 4,000 young girls. And because we just introduced the period kits last year, we have distributed over 300 period kits. And we are going to even distribute more during the International Day for Menstrual Hygiene Day. So the borderline or the core thing I want us to go home is that there is a unique relationship between maternal health and menstrual health. A young girl that is well educated and have access to quality sanitary products is a young girl that there will be a reduced vulnerability to teenage pregnancy. There will be reduced vulnerability to infections, and her maternal outcome will be positive. Thank you very much.
Thank you so much, Mrs. Nkechi Ibe, for your phenomenal work with young girls who would eventually grow up to be women. So in a way, you are a key player in promoting the maternal health in Nigeria. Thank you so much. Before I call on the next abstract presenter, I'd like to confirm the availability of our panelists, the fourth panel session. So when I call on your name, kindly indicate so that you can move forward for easy identification. Dr. Emmanuel Oyenuche, is he around? Okay. Dr. Latif Akinola. Okay. Dr. Tosin Maje Kondumi. Dr. Mrs. Ario Rafiat. Okay. And Dr. Oluwatoni Adeyemi. Okay. Thank you so much. So I'd like to call on the next abstract presenter who would be talking to us on knowledge, attitude, and preventive practices related to malaria in pregnancy amongst pregnant women attending antenatal clinic in Lagos University Teaching Hospital. Thank you so much. Can we have the slides uploaded, please?
Thank you. Okay, by way of introduction, we all know that malaria is a very common disease in this part of the world. And it is sad that despite being preventable and treatable, a lot of women still come down with malaria, particularly women that are pregnant. Malaria is caused by a Plasmodium parasite and it's transmitted by a female Anopheles mosquito. Malaria in pregnancy is a major public health problem as it is a leading cause of low birth weight, prenatal mortality, and maternal anemia in endemic communities, even maternal death. The World Health Organization estimates 300 to 500 million malaria cases annually, with 90% of this burden being in Africa. As we all know, universal health coverage is the key to success. So it is important that the people who are at the most risk of contracting malaria should have access to a thorough knowledge of malaria, its prevention, and whenever they come down with malaria, how to get diagnosed and get treated. In addition, the estimated annual mortality attributed to malaria is 700,000 to 2.7 million globally, and more than 75% of the affected are African children and pregnant women. So I carried out this study in order to determine the level of knowledge of malaria in pregnancy among pregnant women attending antenatal clinic in Lagos University Teaching Hospital, to assess their attitude towards malaria in pregnancy, to determine the practices to determine their preventive practices and to also determine the factors that are affecting their preventive and non-preventive practices. It was a descriptive cross-sectional study carried out among 200 participants from antenatal clinics. Participants were selected using a proportionate stratified random sampling method. The questionnaire was semi-structured, it was interviewer administered, and it was tested. Data was analyzed using EpiInfo. Chi-square and Fisher's exact tests were used to determine the association between variables, and the level of significance was set at p less than 0.05. After analyzing, found that in order to determine the knowledge of respondents of malaria, questions like what causes malaria, what are the symptoms of malaria, what causes the presence of malaria in our surroundings were asked. And it was found out that about 53% had good knowledge of malaria in pregnancy. And to determine the level of knowledge of respondents on malaria in pregnancy, questions like what are the effects of malaria in pregnancy were asked amongst respondents. Questions like how do we prevent malaria in questions were asked. And it was found out that about 42% had good knowledge of malaria in pregnancy. In assessing the attitude of respondents towards malaria in pregnancy, I asked questions that was suggestive of their health-seeking behavior. Questions like when you come down with malaria, what do you do? You go to the hospital, or do you treat yourself, or do you take agbo, or do you even complete your malaria treatment? And it was found out that about half of these women had negative attitude towards malaria in pregnancy. And in order to determine the preventive practices of the respondents towards malaria in pregnancy, questions about the different preventive questions about the different preventive questions about different preventive practices available were asked, and then found out that about 6% had poor preventive practices towards malaria in pregnancy. Despite a good knowledge of malaria, it was found out that despite the good knowledge of malaria among half of the respondents, this study was found out that a lot of them do not have quite a good knowledge of malaria in pregnancy. Quite a good knowledge of malaria in pregnancy. And this may be in this study, the use of insecticide nets was used to determine the preventive practice. Although there are different methods of preventing malaria in pregnancy, the use of insecticide treated nets was used to determine their preventive practice. And majority of the respondents did not make use of insecticide treated nets. Some attributed the non-use to heat, and some said this was not. And this was not in finding with a study they did in Lagos State. Okay. This was not the same as the finding they did in Lagos State, where a lot of the women there were using insecticide treated nets. Okay. Also, at the end, there was an association between knowledge and preventive practice, because it was statistically significant that people who had good knowledge of malaria also had good preventive practice. In conclusion, the study found most of the pregnant women studied at Luke had poor knowledge and poor preventive practices, with about 51% having positive attitude towards malaria in pregnancy. For better outcomes of malaria in pregnancy, to prevention and complications, there's need for improvement in health education for pregnant women at the antenatal clinic. So it's not just about telling them to use their drugs or telling them that have they used fancy or are they using their insecticide treatment. It's important to let them know the effect of malaria. That if you have malaria in pregnancy, you can actually die. You can actually give birth to premature babies. You can actually have stillbirth. You can actually give birth. You can actually have death of babies in utero. Thank you for listening. Yes.
Are there any questions for her?
Good afternoon, all. And pregnancy. Okay. Did you actually try to find out the knowledge of the women? Sorry, their level of education. I believe those that come to Lutz at Idiaraba, maybe they'll have some level of education. And then can you also try to classify Idiaraba, whether it is a rural or urban area, which can also guide us in your findings? Thank you.
Thank you for the question. A lot of the women that were attending Lutz were more of, they had their work already, like and a lot of them had their care, and most of them were had work, level of education. And then in Yaraba, it is a tertiary institution. So we had people from different walks of life. I cannot exactly say it's the rural, although it's okay, we can say it's rural.
Okay, thank you so much for your presentation and for actually making our time to research on this, because malaria and pregnancy is quite worrisome, you know. I just want to know, so you focus on insect-treated nets, and to be honest, Nigeria is very hot now, and even if you do this research over and over in the next 5 years, you're going to get low use of insect-treated nets. So I want to know, did you explore the factor like the use of the intermittent preventive therapy? Because of the weather, to be honest, we need to be realistic. So are these women getting intermittent preventive therapy for malaria during pregnancy the way it is currently recommended? If yes, fine. If no, probably we have more of them not getting it. What is the factor in preventing that? Is it that the hospital is not making it available, or that they had collected it from the hospital? So if you do not do it, maybe it's a kind of thing, maybe you want to review the research, what to add in your research. Thank you.
Thank you, Ma, for your question. Yes, I considered fancy that when doing this project. Well, as at the time of administering the questionnaire, I found out that some of the women, they came for booking, and some of them, their gestational age was not yet up to the eligible gestational age to get fancy that. So I cannot exactly say they do not have a good preventive practice, because they were not yet eligible to start fancy that. And some of them, they were SS. They are like, no, they are on paludrin. They are not using fancy that. So I cannot say that they have a poor preventive practice. That's why I did not use fancy that to analyze. But they're actually getting fancy that in loop. Thank you, Ma.
I also have an addition. So when you have such respondents who don't meet your inclusion criteria,